Welcome everyone to our second prom session of this match. So today we are going to start our first session of neurology. So from the neurology, in the long clinical consultation of MRCP PACES exam in the last 4 years, these are the prompts that has come. The neurology is going to be a little bit longer. So the prom session has been divided into 3 parts, only for neurology. This is neurology part 1, 2, and 3. And today we are going to discuss neurology part 1. So before I start, may I know, is my voice loud and clear? Am I audible to all?
Yes.
Yes,
Okay.
sir.
Thank you. So let's start. So today, our first neurology session, this is neurology part 1 prom session. Today, we are going to discuss approach to 5 prompts. They are dizziness, collapse, then vision problem, transient weakness, and tremor. So let's start. Some voices coming. I'm requesting the doctors to mute yourself unless you have some questions. Actually, this session is going to be a little bit interactive. All the prom sessions are interactive. So anytime anyone has any kind of question, please feel free to interrupt me anytime, because I want you, everyone, to make it understand all the things. So our first approach is dizziness. Actually, dizziness is a big term. It can, dizziness can be, it can be due to presyncope or lightheadedness, or dizziness sometimes means vertigo or spinning sensation. So presyncope or lightheadedness, it is actually a state of reduced consciousness. And whenever the consciousness is fully impaired, we call it syncope. Excuse me, some voice is coming from background. I would like to request the doctors to mute yourself.
عايز الدال؟
حديد عادي ولا مغسول؟
Doctor, please mute yourself.
أنا شوف شعري طيب.
I'm not finding where is it coming. Okay, I think it has been muted. So dizziness is a vague term. It can mean lightheadedness, which is presyncope. It is a state of reduced consciousness. And whenever the consciousness is fully gone, we call it. So again, the sound is coming. Can you please mute yourself, doctors? I'm not finding from where the sound is coming. Okay, I think it's perfect now. Okay, so the thing is sorted out. I have muted it. So let's progress. So dizziness means presyncope or vertigo. Presyncope is lightheadedness, which is a state of reduced consciousness. And whenever the consciousness is fully gone, we call it syncope. So presyncope can lead to syncope. This is just a vague term, but before proceeding to the dizziness pathophysiology approach, I want everyone to understand one important thing. That is the circulation of brain. So this is our heart. From the heart, the ascending aorta arises. This is the ascending aorta and this is the arch of aorta. From the arch of aorta, 3 branches arise. They are brachiocephalic trunk, left common carotid artery, and left subclavian artery. From this arch of aorta, actually, the blood supply of the brain arises. So we need it to understand what is the blood supply of the brain. The blood supply of the brain can be divided into 2 parts. One is anterior circulation, and another is posterior circulation. So this is the common carotid artery. Whenever it ascends upward, like this, it has some bifurcation. It is divided into external carotid artery and internal carotid artery. Then this internal carotid artery, after entering into the cranial board, it divides into two parts. These are anterior cerebral artery and medial cerebral artery. So this internal carotid artery actually comprises the anterior circulation of the brain. It has particular importance. Why I'm discussing this part during approach to dizziness or the pre-syncope. So each of the cerebral hemisphere gets its blood supply from the anterior circulation, from medial cerebral artery and the anterior cerebral artery. So right internal carotid artery comprises the right anterior circulation, and left internal carotid artery comprises the left anterior circulation. And medial cerebral artery supplies this part, and anterior cerebral artery supplies the medial part. Then come to the posterior circulation. This is the arch of aorta. From the brachiocephalic trunk, from the right side, the right subclavian artery arises. And there is a left subclavian artery which directly arises from the arch of aorta. And from each of the subclavian artery, an artery named vertebral artery arises. And this vertebral artery forms the basilar artery, and from each of the vertebral artery, the anterior spinal artery arises. And from this basilar artery, all the branches of the posterior circulation actually arises. They are superior cerebral artery, then posterior cerebral artery, then anterior inferior cerebellar artery, and also posterior inferior cerebellar artery. Why I'm discussing this point? This is particular importance. If you notice the brain, it has two parts, right side and left side. And for each side of the brain, each has separate arteries. So may I know if this part is clear to all, the circulation of the brain? Any confusion up to now? Should I repeat it?
No.
Okay. Now you will understand why I have discussed this part. Now let's talk about the consciousness of our brain. Consciousness actually is a very mysterious term. Scientists are not itself clear what actually causes the consciousness, what actually controls it. But in short, we can tell that in order to have perfect consciousness, we need intact cerebral cortex, and it is right and left cerebral cortex. And also, we need a particular part of the brainstem. This is called ascending reticular system. And all of you have already seen that brainstem has two parts. This is the brainstem, midbrain, pons, and medulla oblongata. All the arteries are divided in two parts, right half and left half. So in order to have perfect function of the brainstem or ascending reticular system, we need both sides of the arteries working perfectly. Is it clear to all? And also, in order to function like, sorry, I'm repeating once again, the consciousness is controlled by the cerebral cortex and also by the brainstem. The cerebral cortex has two parts, right part and the left part. And the brainstem has a particular part inside it. It is called ascending reticular system. This ascending reticular system actually resides inside the midbrain, pons, and upper part of the medulla oblongata. And this brainstem, ascending reticular system, actually controls the arousal. And the cerebral cortex controls the awakeness. Is it clear to all how the consciousness is clear? How the consciousness is created? So if anyone has intact right cerebral cortex, even he is having problem in the left cerebral cortex, he will not have any impairment of consciousness. Again, this goes to the same. If anyone has right-sided brainstem problem, but he has intact left-sided brainstem, then it will not cause any impairment of consciousness. Why I'm telling this? Because all of you know that stroke can happen in anterior cerebral artery or the middle cerebral artery, but whenever stroke happens at one part of the cerebral artery, the patient will not have loss of consciousness. This is the take-home point of today's session. This also goes to the same regarding the posterior circulation. If anyone never ever any stroke or TIA comes with decreased level of consciousness. I think this point has not been clear to all. Dr. Losita, have you got the point what I'm wanting to tell?
Yes. Hello.
So do you think that any TIA or stroke patient can come with loss of consciousness?
No, sir.
Can you explain it why?
Because imagine the right side brain hemisphere is affected.
Yes.
The left side still controls some part of consciousness. So I assume
Yes.
consciousness intact.
Yes, doctor. So do you think that TIA can come with a loss of consciousness samely? Dr. Losita?
Yeah. So a TIA.
Yeah, TIA.
A transient.
Suppose posterior
maybe.
circulation TIA affecting the right-sided brainstem.
Less likely.
Less likely because the left-sided artery is working properly. And unless the brainstem encircling reticular system loses all the blood supply, you will not lose the consciousness. So in order to have loss of consciousness, any part, either both of the cerebral hemisphere has to lose its function or the brainstem has to stop its function. And in order to have that, both the right-sided and left-sided artery has to be affected simultaneously. Have you got it, Dr. Rosita?
Yes, Doctor, it's very clear now.
May I know if this part is clear to all? Because this is something very much important to understand. It becomes very much confused to all of us that we think that transient loss of consciousness can happen due to any TIA or stroke, but this is never possible. Let me ask to one another doctor. Dr. Devashish, are you hearing me? Dr. Devashish? Have you got it, doctor? Dr. Sharma? Can you hear me, doctor?
Yes, sir. Could you please repeat that again, please?
From the beginning?
No, just the consciousness part.
Okay. I think I need to repeat it from the beginning. So
Yes, sir.
Okay, thank you. Let me talk again about the consciousness. Consciousness has two parts. One is awakening, another one is arousal. Awakening state is controlled by the cerebral cortex. It is just a rough idea. And arousal state is controlled by the brainstem ascending reticular system. So this is the rough idea. If anyone loses the awakening state, he will have loss of consciousness. In the same way, if anyone loses the function of ascending reticular system, again, he will have loss of consciousness. But the funny part is that the cerebral cortex controls the awakening, and it is actually both the cerebral cortex. That is the right one and the left one. So in order to have a loss of consciousness, both the right-sided cerebral hemisphere and the left-sided cerebral hemisphere has to be off simultaneously. Is it clear now, Dr. Sharma?
Yes, sir. Both should be.
Yes. So suppose a patient has come to you with right-sided hemiparesis. What do you think? What side of the brain is affected? Dr. Sharma?
Sir, could you repeat that? I didn't hear you.
Okay. Suppose a patient has come to you with right-sided hemiparesis. So the patient is having affection of the cerebral cortex. So which-sided cerebral cortex?
Left side.
Left-sided. But the right-sided cerebral cortex is working properly. So
Yes.
do you think the patient will have impairment of consciousness?
No.
And that is the reason in our practical life, we don't see any patient coming with loss of consciousness or even in light-headed state who is having stroke. Is it clear now to you?
Yes, yes, very much.
Same thing happens for the posterior circulation stroke. In our posterior part of the brain, this is the posterior part, and this comprises the posterior circulation. What comprises the posterior circulation? This is the arch of aorta, and from the arch of aorta, this brachiocephalic trunk, common carotid, and subclavian. This is called BCS. And from the brachiocephalic trunk, in the right side, this subclavian artery arises. From the left side, left subclavian artery arises. And from each side of the subclavian artery, one vertebral artery arises. They form basilar artery. And from this basilar artery and the vertebral artery and all the branches of the posterior circulation actually takes on. From the right side, it creates posterior inferior cerebral artery. Then it is anterior inferior cerebral artery. Also in the left side, one pair of anterior inferior cerebral artery and one pair of one again posterior inferior cerebral artery. So suppose if anyone is having right-sided anterior inferior cerebral artery stroke. So what do you think? The patient, what part of the brainstem is affected? Dr. Shama?
You said right-sided anterior ICA is affected.
Affected. So which part of the brainstem is affected? Right side or left side?
Right side.
Yeah. So what do you think? The left side is working properly.
Yes.
So do you think the ascending reticular function will lost its action right now?
No, it won't because one is intact.
Yes. That is the reason posterior circulation stroke also does not present with impairment of consciousness. But the posterior circulation stroke can present with some other manifestation. What is that? That is vertigo. That can come in the PACES exam with the prompt of dizziness. Vertigo has two types of causes. One is central cause, another one is peripheral cause. What are the central causes of vertigo? Our brainstem has three parts: midbrain, pons, and medulla oblongata. Inside the midbrain, third and fourth cranial nerve nucleus is there. Inside the pons, 5, 6, 7, 8 cranial nerve nucleus are there. Some sound is coming. Can you please mute yourself, doctor? Okay. And inside the medulla, 9, 10, 11, and 12 cranial nerve nucleus is there. So, all of us know that inside the pons, 8 cranial nerve nucleus resides there. And whenever there is any impairment of 8 cranial nerve nucleus, this can cause spinning sensation or vertigo. Again, if there is any cerebellum affected for any type of cause, then it also creates vertigo. Regarding, okay, the sound is coming again. Doctor, can you please mute? Yes. I'm not finding. Dr. B, can you please mute yourself? Okay. So these are the causes of vertigo. One is central, another is peripheral. Among the central cause, these are 8 cranial nerve and cerebellar cause. And the peripheral causes of vertigo are it is a cranial nerve 8 itself, and also the inner ear. So again, I'm coming to who is there? Dr. Shama, are you there?
Yes, sir.
So what do you think? If there is anterior inferior cerebral artery affected, what manifestation it can create? Like in this pons, what are the cranial nerve nucleus that resides?
The 5, 6, 7, 8
Yes.
cranial nerve nucleus. So it will cause a central vertigo.
Yes, because the anterior inferior cerebral artery, it is not only supplying the 8 cranial nerve nucleus, it is also supplying the cerebellum. And this is why in our real life, posterior circulation TIA or posterior circulation stroke can present with a complaint of vertigo. It can also present with a complaint of dysphagia, because 9-10 cranial nerve nucleus is inside the brainstem. But it will never cause impairment of consciousness unless there is bilateral stroke, which is very rare. And in the PACES exam, it will never be given. So before proceeding on our next part, may I know if this portion is clear to each and everyone?
Sir, I have a question.
Sure, doctor.
So what's the basic difference between awaking and arousal, please? Sir,
Okay.
I am not clear.
Actually, I have also not found it. What I understand that awaking means, suppose you have waken up from the sleep, but after awaking from the sleep, you will not be, the arousal state is whenever you are waking up from the sleep. But right after awaking from the sleep, are you able to notice the activities around? Dr. Shabab?
Yes, sir.
Suppose in the morning, you have waken up from the sleep.
Okay.
So right after getting up from the sleep, are you able to notice everything around you? Just getting up from the sleep. You have just arousal from the sleep. But
no, okay. Maybe no, sir.
Okay. Gradually you become awake. You notice
Yeah.
your surroundings, like what is there in the table, what is there in the outside of the window. This is awakening.
Okay.
So it is just a gross idea. The scientists itself are not confirmed what causes the actual consciousness. But it has been found that in order to have loss of consciousness, both the cerebral hemisphere has to be affected simultaneously, or the brainstem as a whole has to lose its function at a whole. Otherwise, the person will not have any loss of consciousness. So it is one condition which can cause loss of function of all. Can anyone guess which is the state? Any doctor? This is called global hypoperfusion. Suppose anyone is having reduced cardiac output. I'm going to discuss it later on.
Sorry, I missed the part.
Sorry. Yes, Dr. Maya?
Sir, please repeat the question. I missed the part.
This part, global hypoperfusion.
Yes, sir.
Okay. Suppose, have you seen any sea? Have you seen the wave?
Yes.
The wave comes and goes near its banks. So suppose in this way, the brain gets its blood supply from the heart. Transiently, if you are able to stop the heart, what will happen then? Will there be any blood supply to the brain? Dr. Maya?
No, sir.
So will the patient lose the consciousness or not? Dr. Maya, can you reply me?
Yes, sir. Sorry, I have a guess. That's why I couldn't hear you. Sir, what was the question? I mean, loss of consciousness will happen there?
Yeah. In order to have loss of consciousness, patient need to have global hypoperfusion. Global hypoperfusion means both the cerebral hemisphere has to lose its blood supply, its function. And when in which state, both the cerebral hemisphere or the brainstem will lose its function. Whenever I just cut off the blood supply. In short, whenever I can reduce the cardiac output.
Yes,
So when,
there will be loss of consciousness, yes.
Yes.
Due to
So
hypoperfusion.
whenever the cardiac output will decrease, it will cause global hypoperfusion. And this is the reason the patient can lose the consciousness. In medical term, we call it syncope. This is very much important to understand for our next discussion, because this is very much important. How the loss of consciousness happens and why it happens. So before proceeding on our next discussion, may I know if this part is clear to all? If this is not clear, please feel free to ask me. I will repeat this from the beginning.
Sir, in the case of strokes,
yes.
if it
Dr.
affects, yes, If it affects the basilar artery, then the patient can go into
Yes, good job. I was expecting this question. Exactly. If it affects the basilar artery, unless then the patient will not have loss of consciousness. You are absolutely mindful, and this question proves this. Good job, doctor. Whenever there is basilar artery stroke, at that point, the patient can lose the consciousness because both part of the brain is affected. This is a common point. Good job, doctor. Any other question? Dr. Faria, may I know, have you got this point? What is the pathophysiology of losing the consciousness and the stroke?
Yes, I have got it.
Okay, Dr. Probir, are you clear about that?
Yes, I am clear about it.
Okay. May I know if this point is clear to all, because this will form the basis of today's discussion regarding approach to disease. If it is clear, please give me a thumbs up reaction so that I can proceed forward. Dr. Shabab, Dr. Probir has got it. Dr. Shongar is clear. Dr. Ishita, are you clear, doctor? Okay, I think all are clear. So let's proceed to the dizziness. So dizziness is a vector. Dizziness can mean vertigo or presyncope. Presyncope means lightheadedness. Patient will feel lightheadedness. In your day-to-day life, you'll see a lot of patients will come to you with the prompt of dizziness. And presyncope or lightheadedness is a state whenever the brain is about to lose the blood supply, but it has not lost it fully, but it can happen anytime. So presyncope can lead to syncope. So whenever in the PACES exam, we are given with a prompt that 45-year-old Mrs. Lily has come with dizziness. What should be our first question? Our first question should be, what do you mean by dizziness exactly? Do you feel the whole world is spinning around you, that is vertigo, or you feel like you are going to pass out, that is lightheadedness or presyncope? If the patient complains that he felt like he is going to pass out, then we have to ask, did you lose your consciousness? This is the most important question regarding approach to dizziness, because from the beginning, we have to divide our differential diagnosis, whether we are going to deal with presyncope or whether we are going to deal with vertigo. Then the next question is duration of loss of consciousness. If the patient complains that he has lost his consciousness, the next question is for how long? If it is less than 1 minute, it is syncope. But if it is more than 2 minutes in the PACES exam, all the time, it will be either hypoglycemia or seizure. Usually, we expect that in the seizure, patient will have some jerky movement of limbs, frothingness of mouth, tongue biting. This is the usual scenario. But sometimes in the PACES exam, they may not give you this typical scenario that patient is having some jerkiness of movement, jerkiness of limbs, tongue biting, frothiness of mouth, soiling of clothes. These are sometimes not given in rare cases. Only the duration is important. That is the reason we have to ask, what is the duration of loss of consciousness? We have to notice whether it is less than 1 minute or more than 2 minutes. Then come to the differential diagnosis of syncope or presyncope. First, I will discuss the approach to presyncope or syncope. Then I will discuss the approach to vertigo. The differential diagnosis of presyncope or syncope is the same. First, I'm going to discuss the differential diagnosis. Next, I will give you a set of questions by which you can rule out all the three. So the differential diagnosis of presyncope and syncope, the mnemonic is National Communist Party. In short, NCP. Here, national means neurogenic cause of syncope. Communist means cardiovascular cause of syncope. And party means two party. One is postural hypotension, another is polycythemia. So let's discuss one by one. So it is just my making the neurogenic cause of syncope. It is not, you will not find it in any books. So why I have termed it neurogenic cause of syncope? Let me explain you the pathophysiology first. Inside our body, there's a particular nerve called vagus nerve. And the vagus nerve has connection with AV node. This is the heart. And this is the AV node. Whenever the AV node is stimulated, it actually closes the door so that the cardiac output, the impulses from the SA node, from the AV node, and from the AV node to the bundle of His is actually interrupted. So by stimulating the AV node, we can actually block the transmission of impulses from the SA node from the atrium to the ventricle. Again, the sound is coming from the back. Doctor, can you please mute yourself, doctor? The sound is coming from the back. Okay. I'm again saying AV node has vagus nerve has direct connection with AV node. And this is the AV node by which impulse can transmit from SA node to the AV node, then AV node through the bundle of His to the ventricle. So if we block the AV node, ultimately the atrium will not be able to empty into the ventricle. And ultimately, the cardiac output will decrease. May I know if it is clear to all how vagus nerve stimulation can cause stimulation of AV node, and by stimulating the AV node, how we can decrease the cardiac output? Is it clear to all, doctors? Please give me a thumbs up reaction if it is clear to all. Okay, Dr. Shawab is clear. Dr. Okay. So there inside our body, there are several ways by which we can stimulate the vagus nerve. These are called neurogenic cause of syncope. One is vasovagal syncope. In vasovagal syncope, due to some unknown pathology, actually the vagus nerves get stimulated. And whenever the vagus nerves is stimulated, it stimulates the AV node. And by stimulating the AV node, we can decrease the cardiac output. Same way, subclavian still syndrome. What is subclavian still syndrome actually? Subclavian still syndrome is there is a particular point where the common carotid artery actually bifurcates, and external carotid artery and internal carotid artery takes rise. Around this bifurcation, there are some nerve plexus arises. These are called carotid plexus. So what happens by progression of age, this carotid plexus becomes hypersensitive. And this carotid plexus has direct connection with the AV node. So by stimulating this carotid plexus in old age patient, we can stimulate the AV node. Eventually, the cardiac output will be decreased. This is how in carotid, sorry, not in subclavian still syndrome, it is carotid sinus hypersensitivity. I've told the wrong thing. In carotid sinus hypersensitivity, by stimulating the carotid plexus, we can stimulate the AV node, which can eventually decrease the cardiac output. Similarly, in situational syncope means suppose anyone is having constipation or anyone is having benign prostatic hyperplasia. At that time, whenever he strains, he actually does some valsalva maneuver. The intra-abdominal pressure or the intrathoracic pressure actually increases. And whenever the intrathoracic pressure increases, it stimulates the vagus nerve. And whenever the vagus nerve is stimulated, it stimulates the AV node, eventually decreases the cardiac output. And this is how in the vasovagal syncope, carotid sinus hypersensitivity, and situational syncope, and the loss of consciousness happens. So apart from subclavian still syndrome, may I know if these three pathophysiology clear to all? Dr. Tejas, Have you got it, doctor? Okay. Now come to the subclavian still syndrome. What happens in subclavian still syndrome? So this is the arch of aorta. And this is the brachiocephalic chunk. This is the left common carotid artery. And this is the left subclavian artery. From the subclavian artery, this is the vertebral artery. What happens in subclavian still syndrome? In subclavian still syndrome, stenosis happens proximal to the origin of the vertebral artery in subclavian artery. So this is the area where the stenosis or where the blockage can happen. So suppose this is the subclavian, left side of subclavian artery, and this is the hand. So this person is doing some activity with his left hand. Whenever the hand is doing activity, it will need increased blood supply. So in case of increased blood supply, when the area is blocked, from where the blood will come? Can anyone guess? Any volunteer doctor? Whenever this area is blocked,
Brain.
the hand, sorry, please
The
repeat,
brain.
doctor.
The brain.
Yeah, how? How from the
Because
brain?
it steals from the basilar. I mean, there is a stealing of the blood from the
Yes, yes, exactly, doctor. So the blood was supposed to grow from in this direction to supply the ascending reticular system to maintain the consciousness. But right now, whenever the hand is working a lot, actually the blood, instead of going to this way, this changes its direction and coming to this. And this is why whenever the patient will start doing activity with his left hand, the patient will lose the consciousness. This case has come at the Rawalpindi Center. That is subclavian still syndrome. This stenosis can happen due to any Takasu arteritis. So may I know if this pathology of subclavian still syndrome is clear to all? This subclavian artery actually is stealing the blood from the basilar artery. That's why it is called subclavian still syndrome. Is it clear to all, doctors?
So it's a
Dr. Ajiz?
subclavian stenosis secondary to Takayasu's arteritis leading to subclavian steal syndrome. This
Yes,
was it.
doctor. Yes. Stenosis can happen due to Takasu arteritis. Stenosis can happen due to atherosclerosis. But in the Rawalpindi Center, it came with Takasu arteritis. Dr. Ajijul, may I know, are you getting these points clear? Okay. So these are the 4 causes of neurogenic syncope. I'm again saying this is vasovagal syncope, where the patient will say you that I was at the market, it was a hot, humid climate, and I was sweating a lot. So there will be some precipitating factor. In vasovagal syncope, it's precipitated by hot, humid climate and sweat. In subclavian still syndrome, the patient will give you some history of doing activity with her left hand. In carotid sinus hypersensitivity syndrome, patient will give you some history of doing shaving or wearing tight collar. And in situational syncope, the patient will give you history of doing straining. Like patient is having constipation and during straining, suddenly he loses the consciousness. But this period of loss of consciousness will be less than 1 minute. Patient will automatically gain back the consciousness. So this is neurogenic causes of syncope. Now come to the cardiovascular cause of syncope. The cardiovascular causes of syncope can be divided into 2 types. One is due to outflow obstruction, another is due to arrhythmia. In both the cases, due to some outflow obstruction, the cardiac output is decreased. Eventually, there is global hypoperfusion happening. This can lead to presyncope or syncope. In the same way, whenever there is arrhythmia, the cardiac output also decreases. There are some pathophysiology. We have to study the cardiac cycle for that. But due to arrhythmia, the cardiac output decreases, which causes global hypoperfusion, eventually presyncope or syncope. So again, outflow obstruction can be divided into 2 types. One is outflow obstruction from the heart, another is outflow obstruction from the lung. So what is outflow obstruction from the heart? This is aortic stenosis and hypertrophic obstructive cardiomyopathy. And in all the cases of outflow obstruction, the patient will give you the history of syncope or the loss of consciousness during exertion. Patient will tell you that I was playing football, suddenly I lost the consciousness. It will never happen in nesting condition. All the time, patient will tell you that whenever I did jogging, I lost the consciousness. It can be due to aortic stenosis or HOCA. So can anyone tell me what important family history we can ask to rule out the HOCA? We discussed it in our first introductory session. Any volunteer doctors? Yes, doctor?
Cardiac
Sudden
deaths.
cardiac death.
Sudden death.
Any
Okay,
young age, sudden cardiac death?
Okay, yeah, you are all right. Let me show it from our introductory session. So in the family history, all the registered doctors have already got this PDF. It is written, any family history of sudden death. And this question has to be asked in case of syncope and palpitation problem to rule out the HOCA. Now come to the lung-related outflow obstruction. So we all know that the heart empties into the ascending aorta from the left ventricle. And the left ventricle gets its blood supply from the left atrium, and the left atrium gets its blood from the lungs. So whenever there is any outflow obstruction from the lung, that is due to pulmonary hypertension, will the left heart get enough blood supply to supply to all over the body? Is it possible, doctor? It will not. This is the reason in pulmonary hypertension, patient can have exertional dyspnea, also exertional syncope. This pulmonary hypertension can be primary or it can be secondary. The primary pulmonary hypertension means there is no secondary causes. It happens usually in the middle-aged female. And the secondary pulmonary hypertension means some valvular heart disease like the mitral stenosis, or it can even can be due to obstructive sleep apnea. In the PACES exam, mitral stenosis case came. So this is how lung outflow obstruction can cause exertional syncope. May I know if this part is clear to all? Any confusion from any of the doctors? Dr. Azizul is clear.
Sir, does it mean that mitral stenosis can cause syncope?
Yes, mitral stenosis can cause syncope by secondary pulmonary hypertension, not by primary. Are you getting it, doctor? Whenever it came at Thiru Center, it came at Pune Center that patient was case of pulmonary mitral stenosis, and he complained of exertional dyspnea, also exertional syncope. It happened due to the secondary pulmonary hypertension. Have you got your answer, doctor?
Yes, sir. Yes, sir.
Okay. Dr. Probir, is it clear to you?
Yes, clear.
Okay. Dr. Shama, clear?
Yes, sir.
Okay. The next cause is arrhythmia. So what can cause arrhythmia? In the first session, already I have mentioned that in the PACES exam, in the long clinical consultation, past medical history, drug history, and family history is very much important. So this arrhythmia can be post-myocardial infarction arrhythmia. The patient can give you some history of past myocardial infarction. So whenever anyone is having past myocardial infarction, this can cause some scarring of tissue in the ventricle or atrium, anywhere, and this scarring can cause foci of arrhythmia. Some electrical activity can happen from this foci. This can be ventricular tachycardia or ventricular fibrillation. Yes, doctor, both bradyarrhythmia, tachyarrhythmia, both can happen. But in case of bradyarrhythmia, the patient will not tell you some palpitation. Yeah, you're right. Bradyarrhythmia, tachyarrhythmia, both can happen. So if we get in the past medical history, any history of MI, we can mention the cause of syncope as post-MI arrhythmia. Then it can be due to drug-induced cause. Can anyone mention what are the drugs that can cause arrhythmia? Any doctors, any volunteer? Very common drugs we use in day-to-day life.
Albuterol.
Sorry, salbutamol? No, doctor. Salbutamol can cause arrhythmia, but that is supraventricular tachycardia, something like that. No, doctor. It is anticholinergic. Haloperidol, yeah, you are right. Haloperidol can cause it. But
Is it
in the
macrolides?
Yes, doctor. In the PACES exam, they give common drugs like macrolides or sometimes antihistamine. And there is a particular question for that. Suppose the patient is having a recent sore throat and recently he has taken some antihistamine. This antihistamine can cause prolong the QT. And this, whenever the QT is prolonged, it can cause arrhythmia. But the important point is that if you don't ask this question, that any recent introduction or withdrawal of any medication, the patient is not going to give you the answer. He will show you some regular medication, like the medications for hypertension or diabetes. But recently he has taken an antihistamine prescribed by the GP, and right now he is having some syncope. So you have to mention arrhythmia, and for the arrhythmia, it can be recently introduced drug-induced arrhythmia due to antihistamine. So unless you asked any recent introduction or withdrawal of medication, the patient is not going to give you the history of recently taking antihistamine. That was the important part, what I wanted to discuss. The next thing is age-related. In the NICE UK guideline, it is written that anyone above 50 years, if he comes to us with any type of dizziness, we have to do ECG to rule out arrhythmia. If nothing is found, we have to do 24 hours ECG. Even if it is not found anything else, we have to go for 7 days ECG. So age itself is a precipitating factor of causing arrhythmia. It has come in the PACES exam, like in a 50 years old patient, if any time comes to you with lightheadedness, we have to rule out arrhythmia by doing baseline ECG, then 24-hour ECG, then we have to proceed to 3 days ECG or even 7 days ECG. Then come to the long QT syndrome. Already I have discussed this long QT can be due to some azithromycin, that is macrolide or antihistamine. The next thing is, yes, doctor.
Should you only mention about the ECG? Can we go for Holter?
Yes, 24 ECG is called Holter, doctor. It is another name of 24 ECG.
Okay.
It is also true for our day-to-day practice. Any elderly patient, if anytime comes with a lightheadedness, dizziness due to lightheadedness, we have to rule out paroxysmal arrhythmia. To rule it out, we have to go for Holter. And the next thing is Brugada syndrome. To rule it out, again, what important history we have to ask? Can anyone mention?
Any family history of sudden death?
Yes, family history of sudden death. All the questions are written in the introductory PDF. So you have to just memorize this, because I'm again repeating, in the PACES exam, past medical history, drug history, and family history, they are actually blessings. If you can ask them right at the beginning, in more than 80% of the time, you will get your diagnosis. But you have to know what questions you have to ask. So Dr. Toslima, do you want to ask any question, doctor? Okay. So this causes the cardiovascular cause of syncope. Now come to the P. P goes for 2P. One is postural hypertension, another is polycythemia. So what is postural hypertension? The mnemonic to remember the causes of postural hypertension are hands. Here H goes for hypovolemia. This hypovolemia can be due to some diarrhea, vomiting, or diuretics, or excessive sweating. Then A goes for adrenal insufficiency and anemia. This adrenal insufficiency is usually due to primary adrenal insufficiency. In the PACES exam, secondary adrenal insufficiency is rarely given. And there are many causes of primary adrenal insufficiency, like the autoimmune cause, that is Addison's disease. It can be due to tuberculosis. It can be due to HIV. These are the probable causes that comes in the PACES exam. And the most common cause is the Addison's and tuberculosis for the Indian subcontinent. Then N goes for autonomic neuropathy. This autonomic neuropathy can happen in long-term diabetes patient and in advanced Parkinson disease patient. Then D goes for drugs. These are vasodilator drugs like the alpha blocker, ACE inhibitor, and diuretics. And ACE goes for steroid withdrawal. I have written this apart from this adrenal insufficiency. Actually, by withdrawing the steroid, patient is having adrenal insufficiency. But as this course is very much important for PACES exam, that's why I have added the S apart from the hand. So this goes for hands or postural hypotension. And all the time, the patient will tell you that I feel dizzy standing from the sitting position. And that's all for postural hypotension. I'm going to give you a written sets of questions. Just by asking these questions, you will be able to rule out all the three. So may I know if this is clear to all, the differential diagnosis of postural hypotension? Okay. The next thing is polycythemia.
Sir, if I may,
So-
could you please repeat the neurological screening questions in the neuro section? The first N.
Doctor, I have not yet discussed the screening question.
Okay, sir.
Actually, I'm going to give you a written sets of questions at the later part in the form of before, during, after. Just by asking these questions, you will be able to rule out all the causes of neurogenic syncope, cardiovascular syncope, and postural hypertension. I'm going to discuss it later on. But right now, I'm just discussing the differential diagnosis. The approach for dizziness or pre-syncope syncope is a little bit different considering the others. Clear, doctor?
Yes, sir.
Okay. The next thing is polycythemia. Polycythemia means increased RBC mass. So the patient is having hyperviscosity. And suppose, what is the job of our blood to the brain? The blood carries oxygen to the brain. But whenever there is enough, whenever we are going to a particular place, if there is enough traffic in the road, can we reach the place at proper time? No. That is actually happening in the polycythemia. In the polycythemia, due to the hyperviscosity of the blood, it is actually not possible to supply proper amount of oxygen to the brain for the blood and also take the carbon dioxide back. And that is the reason in polycythemia, also the patient can feel dizziness due to lightheadedness. And this case has come in the PACES exam. So this is particularly popular case for Kolkata Center. There is a case there which comes with polycythemia with the prompt of dizziness. And the dizziness is due to lightheadedness. So there are two types of causes of polycythemia. One is primary, that is polycythemia rubra vera. This is not a PACES case. Another is secondary. The secondary polycythemia can happen due to obstructive sleep apnea or any cardiac disease, congenital heart disease, like VSD with Eisenmenger syndrome or tetralogy of Fallot. This VSD has come at Thiruvananthapuram and TOF has come at Kolkata Center. And also this obstructive sleep apnea case has come at Thiru Center. So may I know if how the polycythemia can cause dizziness? Is it clear to all? Dr. Shabab is clear? Yes, doctor? Dr. Shama is clear? Okay, Dr. Fariha is clear? Let me see. Okay. Dr. Naveen, are you clear, doctor? Dr. Taslima, are you clear?
Yes.
Okay. So let's proceed to the main part now. All of the differential diagnoses regarding the neurogenic, cardiogenic, and postural hypertension, not the polycythemia. Only the neurogenic, cardiogenic, and postural hypertension can be ruled out by asking three sets of questions. These are before, during, and after. Right now, I'm starting the core part of our discussion today. Up to now, I have discussed the pathophysiology of dizziness, consciousness, and then what are the differential diagnoses. Right now, I'm going to give you the gist thing. So just by asking this before, during, and after questions, you'll get your diagnosis. How? Let me discuss. Among the before, during, and after, the most important one is the before one. we have to ask what were you doing and how were you feeling. Regarding doing that, what were you doing before this episode? And regarding feeling, did you feel any unusual sensation before this episode, like racing pacing of heart, feeling sick or excessive hot, any smell or tummy discomfort? This is the aura for any seizure. Let me ask you a question. Suppose the patient is telling you that he was doing jogging and suddenly he lost the consciousness. What do you think? What is the cause of syncope? And during before being fainted, he felt some tightness of chest. Any doctor?
Outflow obstruction.
Yes, doctor. This is outflow obstruction. It can be cardiac outflow obstruction or lung outflow obstruction. Good job. Suppose the patient is telling you that he was doing marketing before this fainting episode. He was in a hot and humid climate. She was doing marketing in a local market and she was sweating a lot. And suddenly before fainting out, she was feeling some unusual sensation, like feeling sick or excessive hot. So what do you think? What is the diagnosis? Vasovagal syncope. Suppose the patient is telling you that, Suppose the patient is telling you that she was doing, she was training during constipation, during defecation. So what do you think that? What is the cause of syncope? Situational syncope. So this is how, just by asking what were you doing and how were you feeling, you can get your diagnosis in most of the cases of dizziness, that is lightheadedness or syncope. I'm going to give you some real PACES cases just after discussing the approach of dizziness and collapse. I will discuss some real cases. I will see how you can give the answer. Then come to the during sets of question. Regarding during, already we have asked that how long the episode lasted. If the patient loses the consciousness. Then we have to ask, do you remember what happened? This is to rule out syncope from pseudosyncope. Because if the patient does not lose the consciousness really, he will know what was happening outside. So we have to rule it out that, do you remember what happened? In the PACES exam, all the time the patient will tell you that, I cannot remember what happened at that period. I just lost my consciousness. Then for all the cases of syncope, we have to rule out the seizure. We have to ask any jerky movement, tongue biting, frothiness of mouth, soiling of clothes during this episode. This is the hallmark questions to rule out seizure. And as we are asking personal question, we have to mention, I'm sorry to ask this question. The third question is, any change of color during this episode? Usually in case of vasovagal syncope, patient becomes pale. And in case of seizure, patient becomes cyanosed. So may I know if anyone knows why in vasovagal syncope patient becomes pale? Do you know the pathophysiology? Do I need to explain it or I can proceed forward?
The blood pressure drops and the heart rate also drops.
Yes, doctor. The blood pressure drops and the heart rate also drops. For some unknown reason, in the lower limb, the peripheral vasodilatation happens and the blood actually pulls downward. That's why the cardiac output, venous return gets decreased and cardiac output also gets decreased. That's why patients become pale. So we have to ask this question. So these are the three questions for during set. Now come to the after sets question. For after, there are again three questions. One is, how did you get back to normal? Spontaneously or by any sugary drink? This is the hallmark question to rule out hypoglycemia for all. Then any confusion, headache, or limb weakness after this episode. Can anyone mention what does it indicate? Confusion, headache, or limb weakness?
Post-ictal.
Yes, post-ictal confusion. Then any injury following the episode. This is the question of safety net. Because if anyone has any injury after losing the consciousness, we have to arrange CT scan to rule out any fracture of the brain or also the spine. In the PACES exam, All the time, the patient will tell you that success. Luckily, I saved myself. But we have to show in front of the examiner that we are safe doctor. And to prove it, we have to ask any injury following the episode. Clear to all? Just by asking these 3 sets of questions, we can rule out any cause of presyncope and syncope except polycythemia. Please let me know, doctors, if this portion is clear to all and if there's any questions from this part. Any question, doctor? Is it clear to all? Should I proceed forward? Please give me a thumbs up reaction so that I can understand that this portion of presyncope or syncope is clear to all. Dr. Faria is clear, Dr. Satish is clear, Dr. Ajijul is clear, Dr. Abbas is clear, Dr. Pravish Sharkar is clear, Dr. Maya is clear. Okay. Dr. Devashish, are you clear, doctor? Dr. Losita, are you clear?
Yes, doctor.
Okay. So what do you think? What should be the screening question to rule out polycythemia? Any volunteer, doctor? Can you guess? Polycythemia is a condition where there is hyperviscosity. So what question can you ask?
Headache?
Yes, headache. Wonderful answer. Headache. So we just have to ask, do you have any headache? It is headache not after the losing of consciousness or presyncope. Yes, we also can ask blurring of vision. But the most important question will be headache, because if the cause is obstructive sleep apnea or VSD, the patient will never complain of blurring of vision. We can choose only one question as a screening question. That is, do you have any headache? Just by asking this question, you can guess your diagnosis that this is a case of polycythemia. So my suggestion is, whenever the patient is complaining of headache, just check for the conjunctiva, palpebral conjunctiva, whether there is any polycythemia or not. If you find any polycythemia, you can guess that this is a case of presyncope due to polycythemia. In polycythemia, actually syncope does not happen. It halts down at the stage of presyncope. And that's all for lightheadedness or presyncope. So now I'm going to discuss the approach to vertigo. Like first, after entering if the prompt is dizziness, we're ruling out that what do you mean by dizziness exactly? Is it, do you feel like the whole world is spinning around you? Spinning around you means vertigo. If the patient complains that, yes, I feel that the whole world is spinning around me. So this is a case of vertigo. So how to approach to a case of vertigo? First, we have to analyze the symptom using the mnemonic OD-para. What goes for OD-para? Already we have discussed it in our first introductory session in this PDF. O means onset. That is, how did it start? Suddenly or gradually. D means duration. For how long you are having these symptoms. I means initial episode. Is it the first time you are having this kind of symptom? P means progression. Is it gradually increasing day by day? A means aggravating factor. R means relieving factor. Just ask anything increase or decrease your symptoms. And A for associated features. In the PACES exam, most of the time, the patient will never give you any associated features positive unless you ask them specifically. So this goes for OD-para. Now come to the approach to vertigo. Vertigo means spinning sensation. The spinning sensation can be divided into 2 types. One is constant spinning sensation, and another is episodic spinning sensation. Constant spinning sensation, to remember the causes, we can use a mnemonic. The mnemonic is vice president of DMC. Here, B goes for vestibular neuritis. P goes for posterior circulation stroke. And this is the most important DD for any type of vertigo. Whatever the types of vertigo is given in the PACES exam, if you find any cardiovascular risk factor in the past medical history, like the diabetes, like the hypertension, like the dyslipidemia, like the smoking, we have to rule out posterior circulation stroke. And how to rule out posterior circulation stroke? Just do the finger nose test to rule out the cerebral involvement. The patient will have no abnormality, But in front of the examiner, we have to check the finger nose test to show the examiner that we are ruling out posterior circulation stroke for all the cases of vertigo. Then D goes for phenytoin, T goes for drugs. These are phenytoin and gentamicin. This actually affects the inner ear, causing vertigo. These are peripheral causes of vertigo. N goes for multiple sclerosis. In multiple sclerosis, cerebellum is affected. And whenever the cerebellum is affected, it can cause vertigo. And C goes for cerebropontine angle tumor. It can cause vertigo. Now come to the screening question. In vestibular neuritis, in the past medical history, patient will give you history of recent upper respiratory tract infection. And this question, this answer, he will never give you unless you ask. So, any recent, another question? Yeah. Any recent infection. If you don't ask this question, if you just ask that, do you have any medical condition I should be aware of? He is not going to give you the answer that recently I had a sore throat. So to make it out, we have to ask, is there any recent history of infection? If there is any recent history of upper respiratory infection, this can cause vestibular neuritis. And this is actually the screening question for this vestibular neuritis. Vestibular neuritis has two parts. One is vestibular neuronitis, not two parts, two types. Another one is vestibular labyrinthitis. And in labyrinthitis, hearing is impaired. Hearing is not impaired in vestibular neuronitis. Then come to the posterior circulation stroke. Already I have discussed regarding the posterior circulation TIA or stroke. It can present with vertigo. So in the past medical history, patient will have some risk factor like diabetes, hypertension, dyslipidemia. Patient can give you a history of smoking. But for all the cases of vertigo, particularly in elderly patient, if we find even one risk factor in the past medical history, we have to rule out posterior circulation stroke by doing the physical examination, by doing the finger nose test. We don't have to check all the steps of cerebral examination. Just doing the finger nose test will be enough in front of the examiner to rule out the posterior circulation stroke. Then D goes for drugs, which will be evident from the drug history. M goes for MS, multiple sclerosis. To rule it out, we have already asked whether this is first time or not. That is the first time you're having this kind of symptom. We know that multiple sclerosis is a relapsing remitting condition. So the patient will have repeated episodes of attack. It can attack in the form of vertigo, or it can attack in the form of vision problem, or it can have attack in the form of weakness of any particular sides of the body. Again, you will get clue in the past medical history. Then come to the CP angle tumor. To rule it out, we have to ask headache. Do you have any headache that is increased by coughing, sneezing, and bending forward? That is features of raised ICP. And this goes for the constant causes of vertigo. Let me ask from the doctors if there is any confusion or questions from the causes of vertigo, that is constant causes of vertigo. Any questions, doctors? Dr. Maya, do you have any question?
No, sir. Thank you.
Dr. Tejas, any question from your side?
No, sir. Thank you.
Okay. Dr. Probir, Dr. Fariha?
No question. Thank you.
Okay. So, if the patient complains that the spinning sensation is episodic, that is, it comes and goes. This means this is episodic vertigo. The episodic vertigo can be divided into two types. One is triggered, another one is spontaneous. So what are the triggered causes of vertigo? There are two triggered causes of vertigo. One is benign paroxysmal positional vertigo, another is postural hypotension. This BPPV case came in the PACES exam. Vertigo is not that much prominent prompt in the PACES exam. It comes very less often, but we have to know how to approach to this. In case of BPV, the patient will tell you that I feel the vertigo, I feel the spinning sensation when I move my head from side to side in lying condition. So whenever we ask this question that anything increase or decrease of symptom, the patient will tell you that, what's the question? Yeah. Anything increase of symptom, the patient will tell you that whenever I move my head from side to side in lying condition, I feel the whole world is spinning around me. So this is a case of BPPV. And again, whatever the cause of vertigo, for all the cases, we have to rule out posterior circulation stroke, because we are proving ourselves as a safe doctor in front of the examiner. Then postural hypertension can cause vertigo. The patient will tell you that I feel the vertigo during standing from the sitting position. Then there are spontaneous cause of vertigo. What are the spontaneous? One is migraine. It is called basilar migraine. It is not actually a PACES case, the basilar migraine. What happens actually in the basilar migraine? In basilar migraine, patient does not have any headache. The only presenting feature is vertigo. This migraine is actually without headache migraine. And this particular migraine is called basilar migraine. Then another thing is Meniere's disease. It is also spontaneous. It happens in case of older age patient. And the screening question for Meniere's disease is oral fullness. So we have to ask, do you feel full inside the ear? That do you feel any sensation of heaviness inside the ear? This is called oral fullness. In Meniere's disease, due to the endolymphatic dilatation, patient feels some fullness inside the ear. And this is the screening question for Meniere's disease. This is spontaneous, but it is episodic. And that's all for the approach to vertigo. So let me ask doctors if it is clear to all. If there's any question or confusion regarding approach to vertigo or not. And this comprises the approach to dizziness. I'd like to have some question if anyone is having any questions. Dr. Maya, Dr. Tejas, any question from your side?
No, sir.
Okay.
No,
If
sir.
there is no question, is clear to all? If it is clear, please give me a thumbs up reaction. Dr. Rita, have you got this point? Approach to vertigo?
Yes.
Okay. So in short, I'm repeating again. We have discussed what impairs the consciousness and what is actually dizziness, how to approach to a case of dizziness. First, we have to differentiate whether the dizziness is due to vertigo or whether the dizziness is due to presyncope or lightheadedness. If there is the patient complains of lightheadedness, we have to rule out the syncope, that did he lost the consciousness. If anytime in the PACES exam, the patient complains of loss of consciousness, the most important next question is duration of loss of consciousness. Because if it is less than 1 minute, it is syncope. If it is more than 2 minutes in the PACES exam, all the time, either it will be hypoglycemia or seizure, nothing else. More than 2 minutes in the PACES exam, it will never be syncope. And the differential, because the differential diagnosis of seizure or hypoglycemia is different. It's not like the syncope. Then the differential diagnosis, the mnemonic is National Communist Party, that is neurogenic, cardiogenic, and postural hypertension. All the neurogenic, cardiogenic, and postural hypertension can be ruled out by asking the 3 sets of questions. They are before, during, and after. Then we have to know, we have discussed the approach to vertigo. And that's all for approach to dizziness. Now we are going to discuss approach to collapse. Yes, doctor? Okay. So in the PACES exam, collapse means all the time loss of consciousness. So we have to ask, this loss of consciousness can be due to syncope, can be due to hypoglycemia, can be due to seizure. So in the PACES exam, if we are given with the prompt of collapse, the next important question is, did you lose your consciousness? If the patient complains, yes, I lost my consciousness, the second question is for how long? If it is less than 1 minute, this is a case of syncope, we have to follow the sets of questions of before, during, and after. Then we have to ask how many times and when was the last time. Then we have to ask the before, during, and after questions, not only for syncope, also for seizure and hypoglycemia. Same sets of questions. We have to ask for in the before, working and feeling. That what were you doing before this episode? Did you feel any unusual sensation before this episode, like racing, pacing of heart, feeling sick or excessive hot, any smell or tummy discomfort? This smell or tummy discomfort, it's epigastric discomfort. This is found in some form of seizure in the brain. These are the questions of aura. So we have to ask the same sets of questions for any case of collapse again. Then during same question, do you remember what happened? Any jerky movement, tongue biting, frothiness of mouth, any change of color during the episode? Then again after, how did you get back to normal? Any confusion, headache, or limb weakness, any injury following the episode? In case of seizure, the patient will complain with this, that I feel confused, I feel a headache. Sometimes he will lead you some clue that I had some weakness after gaining back the consciousness. So the collapse approach will be the same. But if it is due to seizure, the collapse due to seizure, what will be our differential diagnosis? Now I will discuss the differential diagnosis of seizure. Seizure. Okay, doctor, some sound is coming from background. I don't know where. Please, doctors, please mute yourself. Whenever we are going to, I'm going to ask the questions regarding any of your confusion, you can unmute them. So there are two types of seizure. One is idiopathic seizure, another one is secondary seizure. Idiopathic seizures is also called epilepsy because there is no primary causes found. It can happen weekend episode, or it can happen for the first time. So if it happens for the first time in the PACES exam, during meeting consent, we have to ensure the referral to the seizure clinic within 2 weeks. These cases come in the PACES exam. It came one time with the prompt of collapse and no secondary causes has been found. So it was the first episode of seizure. And it has been written in the NICE clinical guideline that whenever anyone is having first unprovoked seizure, we have to ensure the referral to the seizure clinic within 2 weeks. Then, if the patient is already diagnosed with seizure and there is happening some recurrence, so what are the causes of recurrence of seizure? These are missed medication, like he is not complying with the medication. This can be missed meal, like today morning he did not take the breakfast. It can be missed sleep, like the patient is doing some night duty, and due to the night duty, he could not sleep properly. This can be a provocating factor of seizure. Then it can be flashing of light, means the patient attended a disco night, and in the disco party, he had some flashing of light over his face, and that flashing of light has triggered the seizure. And last thing is stress. Idiopathic seizure, actually in the PACES exam, it is very much less important. It came only one time with the first episode of seizure. The thing is important is the secondary seizure. So what are the causes of secondary seizure? To remember the causes of secondary seizure, I have prepared a mnemonic. It is called big monsters invade daily. So big means brain. There are some brain cause of seizure. One can be ixol. Whenever the cause is due to any intracranial space occupying lesion, in the PACES exam, either it will be due to tuberous sclerosis or neurofibromatosis type 1. So right after entering the station, if we find that patient is having some facial angiofibroma that is found in case of tuberous sclerosis, that case is seizure due to ixol. It can be due to post-stroke seizure. These cases also come. It can be due to cerebral venous sinus thrombosis, like the patient had past medical history of SLE, and the patient also takes oral contraceptive pill, and recently she had some loose motion that precipitated the cerebral venous sinus thrombosis. For cerebral venous sinus thrombosis to happen, patient must have some risk factor and some precipitating factor. Here, the risk factor was taking OCP, and the precipitating factor was loose motion. Due to the loose motion, she had some dehydration, and the dehydration actually caused the cerebral clot formation inside the vein of the brain. Then metastasis. These are the causes that have come up to now in the PACES exam for the brain-related cause of seizure. I'm going to discuss you one by one. I'm going to give you some real PACES cases to see how you can reach the diagnosis. Then monster means metabolic. This is the most important cause of seizure for the PACES exam. This can be due to hyponatremia, like patient is having long-term smoker, and right now he had some seizure. So long-term smoker, can anyone guess that any long-term smoker, now he's having loss of weight, loss of appetite, and also seizure. What can be the cause?
It can be due to bronchogenic carcinoma with SHIAD.
Yes, doctor. Bronchogenic carcinoma with SHIAD due to low sodium. For all the cases of seizure in the PACES exam, during starting physical examination, we have to start to measure bedside blood sugar. It is a must for all. All the time, we have to rule out hypoglycemia. For whatever the cause of seizure is, during starting the physical examination, we have to offer to check bedside blood sugar. Regarding the physical examination, I'm going to give you some organized sets of examination for seizure. And you have to just make it note from the physical examination video, and you have to just follow it. Then it can be due to hypocalcemia. These cases come multiple times in the PACES exam. All the time, it comes with the past medical history or surgical history of thyroid operation. And all the time, the patient will wear handkerchief around the neck, so that you cannot identify the thyroidectomy scar. And unless you ask the question, for the past medical history, we have to ask, do you have any past medical condition I should be aware of? For this case, she will deny. But whenever you will ask any surgery before, then she will give you the answer that, yes, 2 years back, I had a surgery of my neck. That is thyroid surgery. So that's why we have to know each and every line of the past medical history, because the surrogate or the patients are instructed in such a way not to give the answer unless you ask the question that any surgery before, or any hospitalization before, or any recent procedure, or any recent infection. Clear? Then renal failure can cause uremic encephalopathy, that can cause seizure. Again, hypertension can cause hypertensive encephalopathy, that can cause seizure. I'm going to give you some real example. The inverse goes for infection. In the PACES exam, infection-related seizure does not come. It has not come, and it will not come. Then daily means drug. Regarding the drug-related causes are the cocaine withdrawal, cocaine-induced seizure, alcohol withdrawal seizure. Both has come in the PACES exam in the United Kingdom, not in the Indian subcontinent or the Middle East. So I'm going to give you some real example how you can rule out. I will show you how you can reach the diagnosis. But what important thing I want to mention is that for all the cases of syncope and seizure or collapse, we have to stop the timing. And in case of seizure, we have to mention the safety net. Because if we don't mention the safety netting, our mark will be reduced in the clinical judgment. So what are the safety netting? We have to mention, avoid hobby like cycling, swimming. Avoid heavy machinery, sharp cutting object. Don't close the door during taking bath. We also have to mention this safety netting during our communication regarding any seizure. But also in the long clinical consultation, if we deal with any kind of seizure cases, we have to mention the safety netting. And this is a must. So that's all for seizure. Right now, I would like to have some interactive session. I will give you some real PACES cases and see how you can reach the diagnosis. But before that, may I know if there is any question or confusion from the approach to collapse?
Hello, sir.
Yes, doctor.
Sir, do we need to stop driving in case of BPP, PV, or in case of this migraine, like in the case
Okay.
of episodic vertigo and all?
Okay, doctor. Good question. Yes, doctor. Okay. So already in the first session, we have discussed that there is a dilemma of driving. For some cases, you will be assured that you have to stop driving. But there are certain cases where you may feel confused that whether I have to stop driving or not. For that scenarios, you can save your back just by mentioning one line. What is the line? The line is stop driving till further assessment. You are not allowing the patient to drive, or you are not telling the patient to stop driving. You are just telling him that till we find out what is actually happening to you, because this is not the end of the session. Right now we are taking history, then we are order some investigation. Once the investigation results are out, we will give you the real diagnosis. So till then, till we sort out what is actually happening with you, I would suggest you to stop the driving. And just by mentioning this line, you can save your back for all the cases. Did you get your answer, Dr. Satish?
Yes, sir. Thank you so much, sir.
Okay. So there is some particular rule in the PACES exam, how you can save your back. And for PACES exam regarding driving, you don't have to memorize the DVLA rule. It is not necessary at all, because in the UK, you will get support for all. If you think you have to stop the driving, you can mention that stop driving, and I'm referring you to the DVLA. But you don't have to mention that for how long you have to stop the driving, whether it is 6 months or whether it is 12 months. Even if the patient asks you that for how long I'm going to stop the driving, refer him to the DVLA. That I'm going to refer you to the DVLA to get the detailed answer. You don't have to memorize. So don't waste your brain by memorizing the DVLA rule. Okay. Any other questions, doctor? So let me see who can give the answer. Right now, I'm going to give you some real PACES cases. These are also available in the case notes. Yes, doctor, any question? And I'll see who can give the answer. I'll understand whether you have understood up to this part. This case came with one time. It is a real PACES case. The case was 45-year-old Mr. Lawrence has come with collapse. So it was collapse means loss of consciousness. And the duration of loss of consciousness was more than 2 minutes. Along with that, he was having some jerky movement, tongue biting, soiling of cloth. All the components of seizures are there. So in short, this is a case of seizure. Now come to the past medical history. Already I have told you that past medical history, jerk history, and family history are the blessings of PACES exam. Let me give you the example for this. In the past medical history, patient has diabetes for 25 years. He has hypertension for 10 years. He has chronic kidney disease for 2 years, and he is taking dialysis for last 1 year. Regarding drug history, he is taking insulin. He is taking amlodipine. And some other medication like hypophos, CKD medication, subcutaneous erythropoietin, and some other medications of CKD. From the outside, also the vitals were given 180 by 120 millimeter mercury. It was written from outside regarding the vitals. So the case was 45-year-old Mr. Lawrence has come with collapse. The vitals were 180 by 120 millimeter mercury. The collapse was due to loss of consciousness for more than 2 minutes, and he was having all the components of seizure, like jerky movement of hands and feet, tongue biting, soiling of clothes. But in the past medical history, he was diabetic, he was hypertensive, he was having CKD, and he was taking dialysis for 1 year. And he was taking insulin, amlodipine, hypofos, and all the other medications. So now come to the real questions. Before answering the differential diagnosis of this case, what important questions should you ask to the patient? Any volunteer doctor?
Did you check blood sugar level at that time?
Yes, this is one important, but I'm just
The last
mentioning.
dialysis.
Yes, who is the doctor? Can you mention your name, doctor?
Sir, Dr. Satish.
Yes, doctor. When did you take your dialysis last time? The patient mentioned that I took the dialysis 1 week back. Usually I take dialysis 3 times in a week. But this time I've taken dialysis 1 week back. So now, doctors, the field is open. Tell me the differential diagnosis of seizure for this case. Volunteer doctors, you can open the mic and give the answers now.
Hypoglycemia.
Yes, one is hypoglycemia.
Uremic encephalopathy.
Yes, uremic encephalopathy.
Hypertensive encephalopathy.
Yes, hypertensive encephalopathy.
Last, when did the patient took last erythropoietin?
No.
It was regularly taken. It was taken once in a week.
Erythropoietin induced.
Yeah.
Dialysis equilibrium syndrome.
Yes. Who has mentioned dialysis disequilibrium syndrome?
Miami.
Okay. Actually, why not dialysis disequilibrium syndrome for this case?
Because
This can
it generally occurs during the dialysis.
Yes, but he has taken dialysis 1 week back.
1 week back. Yeah.
Yes.
Back.
So you can
1
mention it as a last. It is a last is dialysis disequilibrium syndrome, but against that, the patient has taken the dialysis 1 week back. Can you mention anything else?
Electrolyte imbalance, sir.
Hyponatremia.
Wonderful. Very good,
Hyponatremia.
doctor. Hyponatremia. Patient is having CKD. So advanced CKD patient can have hyponatremia. So have you seen, just by asking the past medical history and drug history, you have got your diagnosis? Isn't it that much simple? Let me give you another case. This is a real PACES case. You will get this case in the PDF case note that is provided to all the doctors, the registered doctors. So this case was 17 years old. Mr. Jackson has come with collapse. Just after entering the station, you are seeing this patient. What do you think? What is
Tuberous sclerosis.
Yeah. So what is the cause of collapse?
Space occupying lesion.
Yes, doctor?
So he has this subcortical tumor, no?
tuberculosis.
Yes.
Hematomas,
Hematoma.
ependymomas.
Yes, due to some intracranial space accumulation. So just by looking at the patient, we can guess our diagnosis. This is how we have to approach to a case of collapse. This is very much simple. So most of the time, I will suggest you that please take the history of past medical history, drug history, and family history with utmost importance. Right after entering the station, like we have to do some introduction. How to do the introduction is written in this PDF sheet. So after introduction and symptom analysis, my suggestion is directly go to the past medical history, drug history, and family history instead of doing the systemic review. Because just by asking the PDF, you will get your diagnosis in more than 80% of the time. After taking the PDF history, complete the SAJIT. SAJIT means smoking, alcohol, job, impaction on job and daily life, and driving. All are written in this PDF sheet. Then if you get time, come to the systemic review. But past medical history, drug history, family history is very much important. And there are some specific questions. If you don't ask these questions, the surrogates are instructed in such a way that they will not give you the right answer. If you don't ask any recent dose change, he will not give you the answer. If you don't ask if any recent introduction or withdrawal of any medication, the surrogate will not give you the right answer. So that's why we have to know what questions we have to ask. So let me ask some other real PACES scenarios. It was 65-year-old Mr. Jackson has come with collapse. From the outside, blood pressure was given 110 by 70. So whenever you're approaching, he was asking, did you lose the consciousness? He said, yes. Today morning, whenever I was doing jogging with my wife, I lost my consciousness. But the period of loss of consciousness was only for 30 seconds. And I get back to normal automatically. So I hope already you have guessed the diagnosis that losing the consciousness during exertion. What can the diagnosis? The thing is that in the past medical history, the patient has told you that recently I have been started with some medication by my GP because I was having some tightness of chest. So my GP told me that I'm having some heart issue. And for this, my GP has started some medication for me. The medications are perindopril, aspirin, isosolvite, dinitrate. So these are the medication that has been started by his GP. And he has lost the consciousness for 30 seconds while doing jogging today morning.
The posture hypertension due to,
So what do you think? What is the diagnosis first?
Outflow obstruction.
Okay, outflow obstruction. And whenever you are auscultating the right second intercostal space, you will finding some ejection systolic murmur. So what is the diagnosis now?
Aortic
Aortic
stenosis.
stenosis.
Aortic stenosis. Okay, that is good. But from the information, do you find any important safety netting here?
The AC inhibitors and isosorbate dinitrate should be stopped.
Yes, doctor, good job. AC inhibitor and isosorbate dinitrate has to be stopped. All of you have already noticed from the MRCP part 1 and part 2 exam that the GPs are made culprit there. All the mistakes are made by them. It is written in the question banks are arranged in such a way. This has happened the same here. The GP thought that it was due to some angina, but he didn't auscultate the heart. So in aortic stenosis, patient can have exertional angina. And this is one of the indications of valve replacement. So the GP thought that it was some kind of angina. That's why he started this medication that precipitated his collapse. And if you don't mention to stop this medication, your mark would be cut in this clinical judgment. So this is a must to mention to the patient that stop this medication right now. Now come to the next part. Can you please mute doctors? Sound is coming. Okay. Thank you, doctor. Now let me tell you the next case. It was a 30-year-old female. Came with collapse. It came at Pakistan sector. So after entering, the patient was telling that I lost the consciousness for only 15 seconds. Actually, what happened? I was cooking in the kitchen. It was a hot and humid climate. And suddenly when I was trying to take something with my hand, on the left hand, I lost the consciousness. But within 15 seconds, I gained back to normal. So, yes. Who has given the answer? Subclavian, Dr. Maya. It's a case of subclavian still syndrome. Any other differential diagnosis you can mention?
Vasovagal syndrome.
Yes, doctor. Sorry, doctor. Postural?
Postural hypotension or vasovagal?
Not postural hypotension, doctor. In postural hypotension, patient will tell you that I feel dizzy standing from the sitting position. But here the patient was mentioning that she was taking something with her left hand. Subclavian SSS stands for subclavian still syndrome. Another DD is vasovagal syncope. Dr. Satish has mentioned the right. This case has come at Rawalpindi Center. The lady was not having pulse at her left hand. Good job, doctor. Let me give you another questions. Constant distraction in the background. Yes, doctor, there's some constant distraction happening. Okay. Now, let me give it another. It was a 39-year-old female has come with dizziness. So after entering, you're seeing that she's an obese lady. She's having puffy face, buffalo hump, moon face, and also lower tummy pink stria. So she's telling that I'm feeling dizzy, particularly standing from the sitting position. And today morning, I had one episode of fits. In the past medical history, she is a diagnosed case of cystic fibrosis, and she has some lung issue. It's called bronchiectasis. In the drug history, she's taking steroid for a long period of time, but recently she has traveled to Australia, and while traveling, she forgot to take the medication with her. And right now she has come to you with a complaint of dizziness, and she feels dizzy during standing from the sitting position. And today morning, she had one episode of fits. So first, let me ask you, what is the cause of dizziness?
Adrenal insufficiency.
Yes.
Due to withdrawal of steroid.
Yes, doctor. And what is the cause of fits?
Postural hypotension due to adrenal insufficiency.
No, doctor. The cause of fits is something.
Hyponatremia.
Hyponatremia can be another cause.
Pulmonary hypertension.
No, doctor. No pulmonary hypertension.
Hypoglycemia.
Exactly. Hypoglycemia. Hypoglycemia. In any kind of adrenal insufficiency, or whenever you approach for the physical examination video for each of the cases given in the case notes, you'll see that I explained here for any type of adrenal insufficiency, we have to offer to check bedside blood sugar. It is a must. This is real PACES case. This came in the PACES exam. It is there. You'll find it in this. Sorry. Okay, it is there in somewhere. You have to search it. Yeah, this was the case. You will find these notes here. 39-year-old Mrs. Jenny has come with dizziness just after entering. You'll see this kind of patient. And in the past medical history, she is a diagnosed case of cystic fibrosis, also bronchiectasis. She is taking prednisolone and pancreatic enzyme supplement due to cystic fibrosis, but the prednisolone was recently stopped. So this is how the case of dizziness comes. Let me stop the dizziness by just asking the last question. This is something different. That's why I'm asking. The prompt was 45-year-old female has come with dizziness. She tells you that I feel dizzy. I feel like I'm going to pass out. That is lightheadedness. And she feels dizzy, particularly standing from the sitting position. In the past medical history, she is recently diagnosed with hypothyroidism, just 1 month back. In the drug history, she is taking thyroxine. But she is noticing that after starting this medication, she is feeling more dizzy. She is feeling dizzy and she is losing weight. So she has read in the internet that thyroxine medication has some side effect. So she thinks that her thyroxine dose is actually being over. That is, she is given more of the thyroxine. Actually, where the dose was 50 microgram. And right now she has come to you that why I'm feeling this kind of dizzy, why I'm losing weight. What do you think, doctor? I'm again mentioning she feels dizzy standing from the sitting position. Any volunteer, doctor?
The postural hypertension due to adrenal insufficiency.
Yes, doctor.
Addiction disease.
Yes. So why do you think she's feeling more dizzy after? Yes, doctor.
So the adrenal insufficiency should be ruled out before starting thyroxine.
Good job, doctor. It is truth for all. Before starting thyroxine, we have to rule out adrenal insufficiency, which was not done for this case. That is why she was losing weight right after starting the thyroxine, because her adrenal insufficiency was precipitated. This is real PACES case. So in the consent part, the patient will ask you that, I think my thyroxine dose is high. Please reduce the dose. So you have to mention that actually from a history and physical examination, what I feel that it is not due to increased thyroxine. It is something due to other reasons, that some part of your gland of your kidney, that is research about the kidney, is not functioning. Dr. Abbas has made the right diagnosis. It is autoimmune polyendocrine syndrome, type 1. That is adrenal insufficiency or Addison's disease along with hypothyroidism. So it is APS. Good job, doctor. So that's how the dizziness, pre-syncope, syncope, and collapse comes in the PACES exam. So we have completed our first 2 prompts of today's session. Before proceeding on to the next prompt, that is vision problem, may I know if there's any confusion regarding the dizziness and collapse? Please feel free to ask me, doctor. You can unmute yourself and you can share your view or you can share your questions. I'll try to clear the confusions from my side. If there is no confusion, please give me a thumbs up reaction so that I can make understand and I will proceed to the vision problem. Dr. Faria is clear. Dr. Anam, do you have any question, doctor? Dr. Tejas, any question from your side?
No, sir, it's fine.
Okay. Dr. Rita, any confusion, doctor? Please don't hesitate to ask the question. Dr. Shanghar, do you have any confusion?
Clear, sir.
Okay. Now let's approach to the vision problem. Again, for understanding the vision problem, we need to understand some detailed pathophysiology. I'll tell you. So what does it mean by vision problem? This prompt can come as a prompt of vision problem, or it can come as a prompt of double vision, sudden loss of vision, or gradual loss of vision. In the PACES exam, vision problem comes under the category of either double vision, or sudden or transient loss of vision, or gradual loss of vision. And in the PACES exam, if anytime any sudden loss of vision comes, it will be transient loss of vision. Because sudden and permanent loss of vision is an ophthalmological case and it is not given in the PACES exam. So whenever the prompt is vision problem, right after entering the exam, we have to ask, what do you mean by vision problem exactly? Is it double vision, loss of vision, or blurring of vision, difficulty in seeing the sights, or problem in night vision? We have to make ourselves clear, what is the vision problem? Then if the patient complains of double vision, we have to approach in this way. So right now, we are going to discuss approach to double vision. But before that, again, we have to understand some detailed pathophysiology. Right now, I'm going to again start some pathophysiological explanation of double vision. And this thing has to be clear to all. So how we see an object? Whenever the ray comes, it passes through the cornea, then aqueous humor, then lens, then vitreous humor, then all the rays coincides at the particular part of the retina. So in this way, from both the eyes, suppose this is the cerebral cortex. So what happens in both the eyes, the rays comes and they fall on a particular part of the retina. Then with the help of the extraocular muscles, the rays fall on the same part of the occipital cortex. I'm again mentioning what is it. So whenever any rays comes to our eyes, by passing the vitreous cornea, then aqueous humor, then lens and vitreous humor, they coincide at a particular part of the retina. And by the help of the extraocular muscles, these rays are ensured to fall on a particular part of the occipital cortex of our brain. and both the eyeballs are coordinated in such a way that both the rays coincides at a particular point, at the same point of the occipital cortex. And that is the reason we see single object. Whenever we are going to see a bottle or anything else, we'll see only single. We will not see double. This is because with the help of the extraocular muscles, it is configured in such a way that the vision is going to form at the same part of the occipital cortex from both the eye. It is not like that from this eye, this is going to happen on this part, and from this eye, this is going to happen on this part. This is not. If the extraocular muscles are in perfect manner, they are well, they can function. If they function normally, they configure the eye movement of the eyeball in such a way that vision from the back of the eye or the retina falls on the same part of the occipital cortex. And this is the reason we see single image. We don't see double image. May I know if this is clear to all? Now let me ask you, suppose this is the right eye and this is the left eye. And for some particular reason, suppose the extraocular muscles of the left eye is not functioning, like the lateral rectus muscle. This lateral rectus muscle is not functioning. So what will happen then? If the lateral rectus muscle is not functioning, the extraocular muscle will not be able to control the coordination of movement of the eyeball, so that instead of right now, the ray will fall on another part of the occipital cortex, not on the same part. So, let me unmute one doctor. Dr. Shonghar, are you hearing me, doctor?
Yes, sir.
So what do you think? This patient, this is same patient. This patient will see single or double?
Double, sir.
Double. Are you clear about that? Do you understand why he will see double?
Yes, sir.
Okay. Suppose he's seeing double because he's seeing using both his eyes. One ray is falling on this part, another ray from left eye is falling on this part. So, Dr. Shonghar, I'd like to hear from you. Suppose by some means, I'm closing this eye. So no rays are going to pass through this way. No rays is going to happen here. So what do you think? This patient will see single or double now?
Now he will see singles.
Have you got the point?
Yes.
Why he will see single? Same thing will happen if we close this eye. We'll see he sees single or double?
Single now.
Yes. And this is the reason in double vision, patient, whenever he will close the one eye, patient will see single. If the pathology is in the extraocular muscles. The extraocular muscles can be affected for many medical conditions. Now come to the next point. Suppose there are some refractory error inside the eye. This refractory error can be due to the lens. Suppose it is due to the lens. So what will happen then? Right after, whenever the ray will enter into the eyeball, it will get dispersed. So multiple ray will form at multiple part of the retina. So again, whenever this eye is going to create image over the occipital cortex, he is going to fall this image at multiple part, not on a single part. But this eye is functioning normally. He is going to create one particular part. So again, now let me, Dr. Tejas, are you there, doctor?
Sir, could you please repeat the question?
Okay, have you understood
Yes,
what
sir.
happened? What happened to this eye?
So there's a refractive error. So it has
yeah, refractive error. So
diverged.
Before going to the cerebral cortex, occipital cortex, he is creating multiple image over the retina. And for multiple image, again, it is creating multiple image over the occipital cortex. There's some detailed pathophysiology. It gets upside down in the occipital cortex. We don't have to know anything details about that. But this eye is creating multiple image in this occipital cortex. But this eye has no refractive error. He's creating only one image. Is it clear to you, doctor?
Yes, sir.
So for this patient, if we close this eye,
he will still have double vision.
Exactly, doctor. Yes. So that is the reason if anyone has intraocular pathology, the double vision will not disappear even after closing one eye. And this is a must-ask question in the PACES exam, because intraocular pathology is an ophthalmological case, which is not a PACES case. But in the PACES exam, we have to show it to the examiner that we can rule out ophthalmic pathology from the intraocular pathology from the extraocular pathology. That's why we have to ask regarding any case of double vision. Whenever you close your one eye, does that double vision disappear or not? All the time in the PACES exam, the patient will reply, yes, it disappears. But even in real life, if you find any patient who is not having disappearance of double vision even after closing of one eye, this means intraocular pathology. And we have to refer the patient to the ophthalmologist for that. As we are proving ourselves as a safe doctor in the PACES exam, working at ST3 level, we have to prove it in front of the examiner that we can rule out intraocular pathology from the extraocular pathology. And the extraocular pathology are all the medicine-related causes. Sorry. I'm extremely sorry. Suddenly, due to some unknown reason, a call had come, and just give me some time. Okay. Am I audible now? Pardon for the mistake. I was suddenly switched off. Am I audible to everyone?
Yes, sir.
Okay. So let me come back to again. All the extraocular pathology is reason something related to the extraocular muscles. So the extraocular muscles can have dysfunction either due to pathology of the muscle itself or due to pathology in the nerves supplying the muscles. The extraocular muscles are supplied by 3 cranial nerves. These are 3, 4, and 6. So any pathology happening in the 3, 4, 6 cranial nerve can cause double vision. And any pathology that affects the extraocular muscles can also cause double vision. Can anyone give me one example what the pathology that can cause affection of the extraocular muscles?
Graves ophthalmopathy.
Yes. What is the cause of affection of extraocular muscle? Yes, myasthenia also. Good job, doctor. Myasthenia gravis ophthalmopathy, also myotonic dystrophy. In myasthenia gravis, in neuromuscular, due to some pathology of the neuromuscular junction, the extraocular muscles cannot function properly. So that's why patient can have double vision. Again, in myotonic dystrophy, this patient has affection of the extraocular muscles. Then in Graves ophthalmopathy, I'm extremely pardon. Okay, is it visible now? Okay, in Graves' disease, due to some autoimmune stimulation of the extraocular muscle, there happens some accumulation of glycose aminoglycan over the extraocular muscles. And due to the stimulation of deposition of glycose aminoglycans, the extraocular muscles become swollen. And whenever the extraocular muscles become swollen enough, it cannot coordinate the extraocular movement. It cannot coordinate the movement of that particular eyeball. That's why the patient can have double vision. May I know if it is clear to all? Dr. Maya, is it clear to you?
Yes, sir.
Okay. So before proceeding on the next part, let me ask to all the doctors whether this portion of double vision, why the double vision happens, is it clear to all or not? Then I can proceed to the next part. If it is clear, please give me a thumbs up reaction. Dr. Faria is clear, Dr. Satish is clear. Dr. Yeah, Dr. Lasita is clear. Okay, Dr. S is okay. I think it's clear to all. Pardon from my side, actually I was having some calls, so that's why frequently the connections were lost. So again, let's come to the part. So if the prompt is double vision, first we have to ask, what do you mean by double vision? Do you see two images of a single object? Because we have to clarify the double vision. Then we have to ask, when you close your one eye, does the double vision disappear? To differentiate intraocular pathology from the extraocular pathology. Then we have to ask, when did it start? Did it start suddenly or gradually? And is it the first time? Right after that, we can jump into the differential diagnosis. The differential diagnosis of double vision are myasthenia gravis, myotonic dystrophy, Graves' disease, sixth nerve palsy or third nerve palsy, or 346 cranial palsy. It can be due to internectal ophthalmoplegia due to multiple sclerosis or Wernicke's encephalopathy. These are the causes that has come in the PACES exam. Among the causes, the most common causes are the 1, 2, 3, and 4. Wernicke's encephalopathy comes in the UK centers. This case is not given in the Indian subcontinent, also in the Middle East. Most often cases are myasthenia gravis, Graves' disease, and 6 cranial palsy. This 6 cranial palsy again can be unilateral or bilateral. If it is unilateral, then it is medical causes of 6 cranial palsy, like due to diabetes and vasculitis. If it is bilateral, it is due to any rest intracranial pressure. So now let me tell you how to rule out by asking the screening question. For myasthenia gravis, we have to ask, do you feel fatty at the end of the day? For myotonic dystrophy, we have to identify just by doing one physical examination that we have to do for every patient just after entering. Can anyone tell me what is the important part that we have to start before proceeding with talking to the patient? And we can
grip
guess that this
grip myotonia,
yes, grip myotonia. We have to do the handshaking. We have to do the handshaking with the patient and looking for any grip myotonia. If there is any grip myotonia present, we can guess the diagnosis of myotonic dystrophy. For Graves' disease, we have to ask the question of weather preference. Then 6 cranial palsy. We have to identify the 6 cranial palsy by identifying the medial convergence of the eye. There is no screening question, but in the past medical history, you have to look for any risk factor, like any diabetes or hypertension. So right after entering the station, if we find that one of the eyeball is diverted medially, then this is unilateral 6 cranial palsy. If it is bilateral, which is not actually a PACES case, it is most often due to rest intracranial pressure. To rule it out, we have to ask the question of headache. But it has not come up to now in the PACES exam. There's no screening question for third cranial palsy and 3-4-6 cranial palsy. We have to depend on approach to ptosis for this case. How to approach to a case of ptosis? Ptosis means, suppose after entering the station, you are seeing a patient having ptosis or eyelid drooping. We have to look whether it is bilateral ptosis or unilateral ptosis. In case of third cranial palsy, it will be unilateral. Then after identifying the unilateral ptosis, our next job is elevate the eyelid and put a torchlight over it to check whether the pupil is constricted or not. Then we have to look for compensatory wrinkling. If there is compensatory wrinkling present, then it is likely myasthenia gravis, because in the PACES exam, myasthenia gravis can sometimes come with unilateral ptosis. And after checking the pupil, if we find the pupil eyeball is in, we have to identify at what we have to identify the location of the eyeball. If it is located downward and laterally, it is third cranial palsy. And if it is located centrally, it is 3-4-6 cranial palsy. Can anyone guess why, by identifying the location at the center, we can guess that this is 3-4-6 cranial palsy? Why I have mentioned this? This is something I have found after seeing a lot of patients. Any volunteer, doctor? Yes, Dr. Padia, can you share your views? Okay, let me share my views. Actually, whenever anyone is having third cranial palsy, the eyeball is moved downward and laterally. And in case of 6 cranial palsy, the eyeball is moved medially. So in the PACES exam, isolated 4th cranial palsy is not given. So whenever eyeball is not moving medially, not moving laterally, so it will locate at the center portion. So just by looking at the eyeball position, you can guess this is a case of 3-4-6 cranial palsy. Is it clear to all? If after entering the station, after seeing the ptosis, after elevating the eyelid, if you find the eyeball is located centrally, you can guess that this is a case of 3-4-6 cranial palsy. You have to prove it by checking the medial movement and lateral movement. May I know if it is clear to all how to identify how to approach to a case of ptosis? This Dr. Losita, have you been cleared, doctor?
Yeah, clear. Clear.
Okay. Dr. Fariha, have you got this point?
Yes, yes, ma'am.
Dr. Shanghar?
Yes, sir. Clear, sir.
Okay. So this is for third, 4-6, and also 6 cranial palsy. For internecral ophthalmoplegia, we have to depend on the past medical history, whether there was any previous episodes of weakness of any particular sides of the body to rule out the myasthenia gravis. Patient can give you some complaint of visual difficulty due to optic neuritis. So clues will be there in past medical history. For Wernicke's encephalopathy, we have to take the alcohol history in details. Like we have to ask, do you drink alcohol? Then we have to check whether it is within social limit or not. And the patient will tell you that he drinks beyond social limit, that is more than 15 units. And whenever there is any excessive alcohol drinking, we have to ask the CAGE questionnaire. That is, first C for cut. Have you ever felt you should cut down on your drinking? A for annoyed. Have people annoyed you by criticizing your drinking? G for guilt. Have you ever felt guilty about your drinking? And E for eye opener. Have you ever had a drink first thing in the morning to steady your nerves or get rid of hangover? And for all the cases of double vision, we have to stop driving. And that's all for double vision. So let me ask from the doctors whether anyone is having any type of question or confusion. Any confusion, doctor?
Sir, what
there
is
is-
compensatory wrinkling? What do you mean by that?
Okay. Good question, doctor. I was intentionally not mentioning this to see who is attentive. Compensatory wrinkling means, doctor, whenever, in case of myasthenia gravis, patient all the time will have compensatory wrinkling. This is something due to weakness of the eyelid muscle. So they will try to mask, they will try to compensate the weakness of the eyelid muscle by wrinkling the forehead. That's why in case of myasthenia gravis, patient will have compensatory wrinkling. Let me show you some real picture. Actually, in this course, we take a free neurology short case session. At that session, this video is shown. So let me show. So what you're seeing in this patient, what is the picture? Doctors, what are the findings you are seeing in these patients?
Left-sided ptosis.
Yes, this is the unilateral asymmetrical ptosis. This is a case of myasthenia. And are you noticing the midline sternotomy scar? Can you guess why is it there?
Thymoma.
Yes,
Thymectomy?
Thymectomy.
Sir, that's what I meant.
Look at this picture, doctor. Are you seeing the linking? This is a patient of myasthenia gravis, the real patient. So in case of myasthenia gravis, to compensate the eyelid weakness, patient do some wrinkling of the foreheads. And this is the patient.
মেনশন করা দরকার নেই দেখছি বলতে পারো আচ্ছা কোনো সমস্যা একটা তাহলে আমার bilateral partial.
So this is the explanation of compensatory wrinkling. Have you got your answer, doctor?
Yes, sir.
Okay. Any other question from the approach to double vision? Okay. Now approach. So this is some examination sequences for myasthenia gravis. This is provided to all the registered doctors. Here we will find how to do the examination sequence for any case of myasthenia gravis. Now come to the next prompt. The next prompt is sudden loss of vision or transient loss of vision. In the PACES exam, if anytime any sudden loss of vision comes, all the time it will be transient loss of vision. Never ever any sudden and permanent loss of vision comes in the PACES exam. So how to approach to a case of transient loss of vision or sudden loss of vision? From the outside, the prompt can be sudden loss of vision, but after entering, you will find that it was a transient loss of vision. So we have to ask, when did this occur? Did it occur suddenly or gradually? Is it the first time? Then we have to ask, did it affect one eye or both eyes? Do you still have the vision problem? Then, for the PACES exam, any type of transient symptoms or all the time, we have to ask before, during, and after sets of questions. Like transient loss of consciousness, then transient loss of vision, then transient weakness. For all the transient symptoms, we have to ask before, during, and after sets of questions. So we have to ask what you were doing before this loss of consciousness, how long the episode lasted, and how did you get back to normal. Then the mnemonic is so many good guys. So means stroke. Strokes due to any embolus. This embolus can be amaurosis fugax or infective endocarditis focus. This case has come first time in the Brunei in this diet. And amaurosis fugax is a very much popular case in the PACES exam. This comes every now and then. Then many means migraine and multiple sclerosis. Good means glucose. This is hypoglycemia. And guy means chancellitis. So right now I'm going to tell you the screening question for it. For amaurosis fugax, we have to ask, did you feel like a curtain was coming down over your vision? Then for infective endocarditis, we have to depend on the past medical history. In the past medical history, the case came at Brunei Center. The patient had aortic valve replacement. And we have to ask for any recent procedure, particularly dental procedure. So the clue is in the past medical history. If in the past medical history, patient gives you history of aortic valve replacement along with recent procedure, also he will give you history of fever, loss of weight, loss of appetite. Then this is due to embolus. Then many goes for migraine. This is some migraine aura. So we have to ask about the headache. MS means multiple sclerosis. So we have to ask any previous episodes of weakness of any particular sides of the body. Then G goes for glucose. We have already ruled it out by asking, how did you get back to normal? And guys goes for Janssen-arthritis. For this, we have to ask, do you have any headache? And the patient will complain of temporal headache. So can anyone tell me that in case of Janssen-arthritis, what association we have to rule out?
PMR.
Yes, doctor. Up to now, it has come in the PACES exam along with PMR. Then for all the cases, we have to stop the time. And that's all for the approach of sudden loss of vision or transient loss of vision. Please tell me, doctor, if anyone is having any type of confusion or questions. Dr. Fariha, do you have any question, doctor?
No, Bhaiya.
Dr. Shama?
No, sir.
Okay. Dr. Satish, Dr. Shanghar?
No, sir. Clear, sir.
Okay. Okay, doctor. Central retinal artery occlusion. One of the doctor have asked central retinal artery occlusion. It is due to the embolus. It is covered in the embolus part. So whenever anyone is having amaurosis fugax, it means he is having transient occlusion of the central retinal artery. It can also happen due to the infective endocarditis, like whenever the embolus will dislodge from the heart and it will occlude the central artery, retinal artery temporarily. It can cause transient loss of vision. But never ever in the PACES exam, permanent central retinal artery occlusion is given. Have you got your answer, Dr. Paramjit? Okay. So this is for sudden loss of vision. Now next proceed to the next prompt vision, that is gradual loss of vision. So how to approach to a case of gradual loss of vision? First, we have to ask when it started. Did it start sudden or gradually? Is it the first time? Then whether the gradual loss of vision is affecting one eye or the both eye. These are the initial questions. Then we have to proceed to the differential diagnosis. Actually, I have mentioned here all the possible differential diagnoses for the real life. But in the PACES exam, only we have to know 5 differential diagnoses. One is cataract, another one is diabetic eye disease and hypertensive eye disease, and the last 2 is retinitis pigmentosa with laser-treated retinopathy. So these are the 5 differential diagnoses that comes in the PACES exam. Other cases you will face in real life, but in the PACES exam, up to now, it has not come. So in the cataract, for any old age vision or gradual loss of vision, we can keep the cataract as the differential diagnosis. If in the past medical history, we get history of diabetes for more than 10 years, in case of type 2 diabetes mellitus, and more than 5 years in case of type 1 diabetes mellitus, then it can be due to diabetic eye disease. If there is any past medical history of hypertension, then it can be hypertensive eye disease.
Sir, could you please repeat the diabetic thing?
Okay. In the PACES exam, sometimes you may be given a case of 2 years of diabetes. But any patient having 2 years of diabetes will not be given with any diabetic complications. In order to have any type of complication, especially the microvascular one, patient need to have more than 10 years of duration of diabetes for type 2 diabetes mellitus. For type 1, it should be more than 5 years. In the PACES exam, they will follow the typical pattern. Is it clear to you, doctor?
Yes, sir.
Okay. Then come to the retinitis pigmentosa and laser-treated retinopathy. This retinitis pigmentosa case has come in the Pondicherry Center. And this is very much easy to identify. Okay, let me tell you that for gradual loss of vision, we need to do the fundoscopy. For this, we have to know how to do the fundoscopy and we have to identify the findings. And for the PACES exam, it is actually not needed to identify the stage of retinopathy, like the stage of diabetic retinopathy or hypertensive retinopathy. It is not needed at all because we are not working there as an ophthalmologist. We just have to identify these 4 things. That is whether there is any papilledema, whether there is any hemorrhage, whether there is any hard exudate and soft exudate. If we can identify only these 4 things, we don't have to even mention at which quadrant we are seeing this. We don't have to mention whether there is flame-shaped hemorrhage or whether there is any pinpoint hemorrhage. It is again not needed. Just mention, I have found hemorrhage, I have found hard exudate, I have found soft exudate, and if there is a papilledema, I have found papilledema. This is more than enough for the PACES exam. And also keep one point in mind that during doing the fundoscopy, never place one of your hand over the patient's forehead. If you do this, it will be considered against the welfare. So in your day-to-day life, whenever you are practicing fundoscopy, try to practice it without touching the patient's forehead. Now come to the laser-treated retinopathy and retinitis pigmentosa. So in the world, if anytime any patient comes to you and say that he's having problem in night vision, he's having tunnel vision, he's not seeing the sight. All over the world, there are 3 differential diagnoses. One is glaucoma, another is retinitis pigmentosa, and the third is laser-treated retinopathy. Glaucoma is an ophthalmological case. It is not given in the PACES exam. So we can rule out glaucoma. It will be not given. So in the PACES exam, if anytime complaints of loss of night vision and tunnel vision, there are only 2 differential diagnoses. They are retinitis pigmentosa and laser-treated retinopathy. If the patient is younger, it will be retinitis pigmentosa. If the patient is older and in the past medical history, he gives you history of long-term diabetes and doing some procedure inside the eye, then this is laser-treated retinopathy. This is that much simple. This case, retinitis pigmentosa came in the Pondicherry Center. It was just a young patient. And right after entering the station, whenever the candidate asked, what brings you here today? The surrogate just mentioned that I'm having night vision, I'm having tunnel vision, and I'm also having difficulty in recognizing the color. That is loss of color vision. At one line, he gave all the answers. Even no extra questions were needed to be asked. So may I know if it is clear to all that how to rule out the retinitis pigmentosa or laser-treated retinopathy? Any questions from any doctors?
No, sir.
Okay. So do you know why in retinitis pigmentosa or laser-treated retinopathy, patient loses the night vision? Any volunteer doctors? Can you explain the pathophysiology? Any doctors? Yes, Dr. Devashish.
With laser at the 10 parts of the retina, except the except the central portion we spare. That's why develops tunnel vision, and also retinitis pigmentosa, they have absent of this nerve layer, maybe. Or I forgot.
Okay, no issue, doctor. No issue. Okay, let me explain it. I think if I explain the pathophysiology, then it will be better to understand. So this is our retina. And inside the retina, there are two types of cells. One is cone cell. These are situated mostly in the periphery. Another is rod cell. Rod cells are situated mostly in the center. So what happens in retinitis pigmentosa? Pathology starts happening from the periphery. So it affects the cone cells first. So whenever the cone cells are affected, cone cells are responsible for seeing vision in the dim light. That is night vision.
Sir, is it not the rod cells which are responsible for night vision? Peripheral.
Sorry. I think I'm making some mess. Sorry, doctor. I'm making some mess. It's a rod cell. I'm extremely sorry, doctor. I think I'm making some mess. It is actually rod cells that are responsible for dim vision. Okay, just a minute, doctor. Sorry, I have come back. Yes, doctor. It's rod cells. Rod cells are situated mostly in the peripheral part, and cone cells are situated mostly in the center. So these rod cells are responsible for seeing in the dim light. And in retinitis pigmentosa, pathology starts happening from the periphery of the retina. And that is why patient loses the night vision first. And in laser-treated retinopathy, also the peripheral portion of the retina is actually treated. So that's why in laser-treated retinopathy, the scars are made at the periphery. That's why, again, the dim vision is lost. Patient is unable to see in the dim light. I'm pardon for myself that I just messed up the rod cells with the cone cells. So is it clear to all why in retinitis pigmentosa or laser-treated retinopathy, patient loses the peripheral vision and the night vision? If it is clear, please give me a thumbs up reaction. Okay, Dr. Faria is clear. Dr. Devashish is clear. Okay, thank you, doctor. So these are the causes that comes in the PACES exam for gradual loss of vision. Optic atrophy does not come in the PACES exam. Up to now, it has not come. It was my mnemonic to remember the cause of optic atrophy, that is myelin toxin. But up to now, I have not seen any cases coming in the PACES exam with optic atrophy, with the prompt of gradual loss of vision. And regarding the retinitis pigmentosa, we need to know some genetic diseases that can cause retinitis pigmentosa. The genetic diseases are Usher syndrome, Cancer syndrome, Refsum's disease, Bardet-Biedl syndrome, beta-lipoproteinemia, or Alport syndrome. Truly speaking, the case that came at Pondicherry Center, that candidate could not mention the associated genetic disease for that retinitis pigmentosa. He could just identify the bony spicules at the periphery of the retina, and he was given 26 out of 28. But if in the cross-questioning, if the examiner asks you some genetic diseases along with retinitis pigmentosa, you can just mention these things. And there are some particular features of each of the genetic symptoms, like in Usher syndrome, along with retinitis pigmentosa, patient will have hearing problem and ataxia. For Refsum's disease, patient will have short fourth metatarsophobia joint, also peripheral neuropathy. In Bardet-Biedl syndrome, patient will be obese. In beta-lipoproteinemia, patient will have loose motion with ataxia. And in Alport syndrome, patient will have hematuria. Also in Cancer syndrome, patient will have heart involvement. So most likely you will find some pacemaker inserted there. The case that came to Pondicherry Center, the patient was complaining of walking difficulty also, along with tunnel vision. But according to the candidate, whenever he examined the lower limb, he did not find any positive findings. He couldn't mention what was the genetic disease associated there, but he was given 26. So that's all for gradual loss of vision. Let me ask from the doctors if there is any question or confusion from this gradual loss of vision. Any questions, doctor? Dr. Tushmit, Dr. Faria, any question?
No question.
Okay. Now let's proceed to the next two prompts. The next prompt is transient weakness. This can be transient hand weakness or it can be transient leg weakness. It's a very much popular prompt in the PACES exam and it will be dummy case all the time. And all the type of transient symptom in the PACES exam, we have to ask the before, during, and after question. Transient symptoms are three in the PACES exam. One is transient loss of consciousness, that is syncope, then transient weakness of hand or leg, and the third is transient loss of vision. Whenever any transient symptoms come in the PACES exam, we have to ask the before, during, and after. So how to approach to a case of transient weakness? We have to ask, when did it occur? Did it occur suddenly or gradually? Is it the first time? Did it affect the hand or leg? Any deviation of the mouth? Because we are ruling out not only the hand weakness, we are ruling out the leg weakness and the deviation of the mouth. That's all the components of the stroke. Then we have to ask before, during, and after questions. That what were you doing? How long the episode lasted? And how did you get back to normal? This is important because we are ruling out hypoglycemia. If the patient complains that after taking some sugary product, I recovered, then this is due to hypoglycemia. Again, I have mentioned here that did it affect the leg or hand? It can come only with weakness of one hand. This was the case in the Delhi center. It was given with weakness of right hand. The patient was a 45-year-old lady. She was preparing a coffee and suddenly she felt the coffee of the hand. And it was weakness of the right hand only. There was no facial deviation. There was no weakness of the legs also. Only weakness of right hand. So what are the differential diagnoses? The differential diagnoses are TIA, hypoglycemia, migraine, multiple sclerosis, and functional. All the cases has come in the PACES exam. For TIA, if we have to look for any evidence of past medical history, cardiovascular risk factor, like diabetes, hypertension, smoking. For hypoglycemia, already we have ruled it out. Can anyone guess by which question? Any volunteer, doctor?
After.
After, yes. We can rule out migraine by asking the headache. It is called out hemiplegic migraine. It is also called hemiplegic migraine. Okay, let me ask you. Suppose you have been given a case of hemiplegic migraine. She is a female, a reproductive age. Whenever you are taking the female history, you are getting that her period is regular. She has a regular partner, and she also takes the oral contraceptive pill. So what important safety netting you have to mention? Any volunteer doctors?
She should go for progesterone only pill.
Yeah, okay. That is that which type of pill, it will be decided by the woman doctor. So we are performing there as a medicine register. What thing we have to mention? What is our job?
OCP.
Yeah. So OCP is a jargon. We have to mention stop the part contouring pill, and I'm going to refer you to the women doctor. to offer you some safer alternative. Because any patient having hemiplegic migraine, if she takes oral contraceptive pill containing estrogen, it increases the cardiovascular risk factor. That is, increases the chance of having stroke or angina or any acute coronary syndrome. That is why we have to stop the OCP. So we have to mention that stop taking this birth controlling pill, and I'm going to refer you to the women doctor to offer you some safer alternative. Then multiple sclerosis. To rule out multiple sclerosis, can anyone guess what should be the question? I have already discussed. Any volunteer doctor?
Before any episode of weakness of the
Yes.
limb.
Already you have asked, is it the first time? Then dysfunctional weakness. This case has come only one time at Pakistan Center. So it is something funny. We have to ask about the mood. What about your mood? Anyone having functional problem in the PACES exam, we have to ask about the mood. And for all the cases, we have to stop driving. And this is weakness, that is transient weakness. It can be given with hand weakness or leg weakness. If it is hand weakness, from the physical examination, to rule out the complication, what physical examination we have to do? Can any doctor who has attended the previous session can tell? Our first prompt session, we have mentioned this. We have to rule out the complication from physical examination. If it is hand weakness, what physical examination we have to do? If it is leg weakness, what physical examination we have to do? Dr. Tejas, can you guess it?
Gripping and buttoning for hand, gait, and
Yes,
back
doctor.
with posture for leg.
Wonderful. Where we meet, doctor? Unmuted, sir. So for the leg weakness, we have to assess the gait. This is a must for leg weakness. And for hand weakness, we have to assess the functional capacity of the hand, because we are working there as a safe doctor, and we have to prove it. The patient will not have any weakness or any type of abnormality in the gait or functional capacity. But we have to check this in front of the examiner to prove ourselves as a safe doctor. And that's all for transient weakness. It is another triple star prompt, and it is very much popular prompt in the PACES exam. It comes with every die, at least 1 or 2 centers. So let me ask from the doctors if there is any questions from this prompt.
Sir, when you say functional capacity of hands, what exactly do you mean?
Okay, functional capacity is being checked by whether the hand is able to do its function. In the PACES exam, you have to mention, can you make a fist and open it for me? You can also tell that button and unbutton your gown for me. These are the 2 ways you can check the functional capacities. You can even tell you that, can you please grip my stethoscope and leave it? Anyway, you can check the functional capacities of hand.
Okay.
Actually, we had a detailed discussion regarding this, because for this course, we follow a particular pattern, that is CCCA. And for all the cases, we have to rule out the complications. For any type of hand complaint, we have to rule out the complications of hand. Like if it is hand pain, we have to check the functional capacities. If it is hand weakness, we have to check the functional capacities. If it is low back pain, we have to check the gait. This is to rule out complications. If it is knee pain, again, we have to check the gait. This is formed in the part of complications. I discussed it in detail in our first prompt session. This session is available in the YouTube channel.
Okay.
Okay, doctor. Now let's proceed to our last prompt. The prompt is tremor or shakiness of hand. This prompt can also come with the prompt of clumsiness of hand. So how to approach to a case of tremor or shakiness of hand? So the prompt is shakiness of hand. We have to ask any other body parts affected, like the legs, like the head, like the voice. Like in essential tremor, patient will have head tremor. It is called head titubation. Patient can have voice tremor. So we have to ask this question. Then this tremor can be resting tremor or action tremor. To rule it out, we have to ask, does it occur during rest or during some movement? Then the third question is, any change in handwriting? Because in essential tremor, the handwriting will become bigger. As the patient will start writing, it will become bigger. But in Parkinson's disease, due to the micrographia, handwriting would become smaller. So these are the three initial questions. Then we have to analyze the symptom using the mnemonic ODPARA. O for onset, how did it start at? D for duration, for how long? I for initial episode, is it the first time? P for progression, is it gradually increasing day by day? A and R for aggravating factor and relieving factor, anything increase or decrease your symptoms. And A goes for associated symptoms. For most of the time, the patient will not give you any associated symptoms unless you ask them specifically. Now let's come to the differential diagnosis of tremor. The mnemonic is end your liver with anxiety, alcohol, and coffee. Here, end goes for endocrine cause, neurological cause, and drugs cause. Liver goes for Wilson disease. And anxiety, alcohol, and coffee can cause tremor. This alcohol is alcohol withdrawal. So let me discuss one by one. Regarding the endocrine causes, there are two causes that can cause tremor in the PACES exam. One is hyperthyroidism, another one is hypoglycemia. Then N goes for neurological. Neurological tremors are three for the PACES exam. One is essential tremor, another one is Parkinson's disease, another one is cerebellar tremor. This cerebellum can be one-sided or both-sided. I'm going to discuss tell you what should be the screening question, how you can identify. Then D goes for drugs. There are several drug-related causes of tremor. This can be beta agonist-induced tremor, like the salbutamol inhaler. Then it can lead to lithium. It can lead to cyclosporine or tacrolimus. Okay, let me ask you, can you guess one disease that is given in the abdomen station where you can get this medical history of taking cyclosporine and tacrolimus?
Renal transplant.
Yes, renal transplantation. Why I have mentioned this? Because in the PACES exam, most often they do this trick. At one carousel, you will examine this patient, like in the first carousel, this patient will be given an abdomen station with renal transplant. But the next day, the same patient can be given at the long clinical consultation with the prompt of tremor. Because the patient is taking cyclosporine, he will surely have some tremor. So that's why we need to understand what phases comes in the PACES exam. Then liver means Wilson disease. To rule it out, we have to ask any family history of liver disease. If there is any Wilson disease in the differential diagnosis, there will be must family history of liver disease. Then the simple things are anxiety and coffee. From my experience, what I have seen, most often the candidates rule out all the critical differential diagnoses. But the simple differential diagnosis like the anxiety and coffee are not ruled out all the time. To rule out anxiety, we have to ask about the mood. And to rule out the coffee, we have to ask, do you take excess amount of coffee? So these are the most common two differential diagnoses that are missed very much. But this is very much easy. Then alcohol goes for alcohol withdrawal. If the patient suddenly withdraws the alcohol after binge drinking, this can cause tremor. So these are all for the differential diagnosis. Now let me tell you the screening question for each. Okay, for endocrine causes, to rule out the hyperthyroidism, we need to ask the question of weather preference. Do you have a weather preference? To rule out the hypoglycemia, we have to look particularly at the past medical history, also in the drug history. And also we have to ask, did you measure your blood sugar during this episode of tremor? This tremor will be episodic. It will be come and go. So we have to ask, did you ever measure your blood sugar? And we have to notice carefully at the past medical history whether the patient is having any diabetes, and in the drug history, whether he is taking any oral hypoglycemic drug like sulfonylurea or insulin. Then come to the neurological cause. For essential tremor, we have to depend on the family history because this is an autosomal dominant disorder. So in the PACES exam, you will surely get a positive family history. Also from the initial questions like any other family parts, body parts affected, he will tell you that I'm having voice tremor, and his handwriting will get bigger, and it will be action tremor. So the tremor will not happen during rest. It will happen during some activity. So you will get some clue there. And just by looking at the patient, you will see that the patient will start dancing. You will have some head nodding in front of you. Then for Parkinson's disease, to rule it out, we need to ask the question of bradykinesia. That do you think you are getting slower day by day? This is the screening question for Parkinson's disease. Now come to the cerebellum. If cerebellum is affected, the patient will lose the balance while walking. And if the patient tends to fall on one side, this is one-sided cerebellum. If the patient complains you that I tend to fall on both the sides, this is bilateral cerebellum. Regarding the differential diagnosis of one-sided cerebral affection, the mnemonic is STD. It is stroke, tumor, and demyelination. For stroke, you have to look at the past medical history, whether the patient is having any component of past medical history, like any diabetes, hypertension, or dyslipidemia. If the patient is complaining of sudden onset of loss of balance while walking, and he is having some risk factor, and whenever he is walking, he is noticing that he tends to fall on one particular side, like the right side. So this is a case of stroke. This case has come in the patient's exam. The other differential diagnosis of unilateral cerebral affection are the tumor and demyelination. Tumor will not be sudden onset, it will be gradual onset. So we have to mention this, that our other differential diagnosis is tumor, that is unilateral cerebral tumor, but against that, the patient is not having any headache. We have to ask about that. And it is sudden onset. To rule out the demyelination, we have to ask any previous episodes of same weakness of any parts of the body. So this is for unilateral cerebellar. For bilateral cerebral affection, we have to ask, first we have to ask that do you lose balance while walking? To which side? If the patient tells you that I tend to lose balance while walking, I tend to fall on both the sides, then it is bilateral cerebellar. For this, the screening question, the mnemonic is, my alcohol can drive gene. Here, my goes for multiple sclerosis. Multiple sclerosis can affect one-sided cerebellum, or it can affect both-sided cerebellum. Then alcohol. Chronic alcoholic patient can have bilateral cerebellar affection. Then can goes for cancer. Any paraneoplastic syndrome can cause some syndrome that anti-WHO antibody and some other antibodies there, which can affect cerebellum of both the sides. Then drive goes for drugs. The drugs that can cause cerebral tremor are the phenytoin and lithium. And gene goes for genetic disease. This is Friedreich ataxia. Truly speaking, up to now, no bilateral cause of cerebellar affection has come in the PACES exam. So you can just remember this, but up to now, I have not found any cases of bilateral cerebellar affection coming in the PACES exam. Only one time, unilateral cerebellar affection has come. This is due to sudden onset loss of balance while walking with past medical history of some cardiovascular risk factor. It was due to some stroke, that is unilateral cerebellar stroke. You will find the case in this PDF, in this 250 KD case note. Then drug history will be evident from the drug history. And to rule out the Wilson's disease, we have to ask about the family history of liver disease. And to rule out the anxiety, we have to ask about the mood. May I know what about your mood? And we have to take the alcohol history in the component of Sajid. And to rule out the coffee, we have to ask, do you take excess amount of caffeine? Sorry, excess amount of coffee. And that's all for differential diagnosis of tremor. Now let me ask you, the prompt is hand tremor. So what examination we can do to rule out the complications of hand tremor? Any doctors?
Again, the functional capacity like buttoning and unbuttoning and also
Yes.
making a fist.
Yes, doctor. So just remember this thing. Any type of hand prompt, we have to check the functional capacity of the hand. And for all the cases of hand tremor, always check for thyroid swelling. It will not be there. But we have to we have to check this. We have to tell the patient, take a sip of water, then do the acting of kneeling down at the patient's neck level and tell the patient to swallow the liquid. It is just an acting to rule out the hyperthyroidism. By checking the thyroid swelling, you are giving an impression to the examiner that you are considering hyperthyroidism as one of the differential diagnoses. And please do it for all the cases of tremor. What sequence of physical examinations you have to do, you will get it in details in the physical examination video for each of the cases separately. So that's all for today. It was a big session, and actually I was a little bit tired. Pardon from my side. I think I could not give my best today. I was having too much tired. That's why I was having some component of dizziness with myself. So today we have discussed the approach to dizziness, collapse, vision problem, transient weakness, and tremor. These are the 5-step prompts. 5-step prompts mean if you notice the previous year scenarios, you'll see that these cases has come multiple times. In our next session, we'll discuss some other prompts. And we'll complete our neurology sessions in total 3 prompts. That is neurology part 1, part 2, and part 3. So after this case, from these 5 prompts, there are some, okay, there are 35 cases in your PDF notebook from case number 1 to case number 35. So this will be your homework. Yes, up to this part. So doctors, tomorrow we'll have a musculoskeletal practice session from one of the batch. So right after completing your musculoskeletal practice, please start doing your homework up to this case number 35. All the cases are arranged according to this prompt, and these are actually real cases. So that's all for today's session. So before signing off, please ask if there is any confusion left from any of the prompt. So this is going to be the last free prompt session of this course. If anyone wants to ask any question, you can feel free to ask. Thank you, Dr. Ifshita. Actually, I was not able to provide the best. I was making some mistake today, like mesmerizing the rod cell and cone cell because I was too much tired today. So if you have any type of questions or confusion regarding the approach to first 5 of the prompts, please feel free to ask me. I would like to make it clear. There's no confusion. Dr. Faria, any confusion from your side? Dr. Mazen, do you have any confusion, doctor? Okay. Dr. Bina, any confusion? Okay. So if there is no confusion, then that's all for today. And regarding the long clinical consultation batch 12, we'll have our practice session tomorrow. And the practice session of batch 13 will be free to all to join. It will be on Tuesday. You can have a look how the practice is done for this course. It is not a blind approach. First, we do the prompt session, then we give some homework in the form of cases and also some detailed physical examinations, investigations, and management. So these are the So these are the physical examinations video. For each of the cases, detailed physical examinations, investigations, and management are recorded here. So you have to make note about that case notes. This is the homework. And then we'll have the practice session. So that's also, doctor. So good night, doctors. Take care. And have a good preparation for PACES exam. Goodbye.